Okay, just testing, 1, 2, 3, I guess. Trying to make sure everything is working here. I'm going to visit YouTube real quick, and hello everybody. Blake on Call is now live. Looks like I'm live there on Twitch. And looks like I'm live here on my locked in live stream. Perfect. And it looks like I haven't yet started streaming on my other platform, but I should do that soon here. Okay, we got one person watching and just getting everything set up. Welcome everybody. Hopefully you're doing well. I'm streaming on Twitch as well, and I'm going to show you guys the chat. We got a countdown timer because we're going to be locking in 30-minute intervals. Perfect. So now we got a Twitch stream going, and we have a couple other things going. So that's awesome. Hopefully you guys are doing swell. I'm just going to get some last-minute things set up, and we'll just start diving into some questions. All right, so let's check this stream. 5 watching, perfect. And then on Twitch, I'll share this in the chat if you guys want to join on Twitch, and then we'll get started. How you guys doing, by the way? This is my first live stream. They'll get better and better over time. I got to figure out a way so I can interact with you guys in the chats. I'm pretty sure on my OBS screen I can see you though. All right, Twitch chat, multi-stream is in read-only mode. Okay, we got to fix that. Stream chat, perfect. And I'm gonna send a message to the chat here. Chat, and if you want to join me on Twitch, then you can do that too. Okay, and almost ready. We're going to dive into some questions. I plan on doing 30 questions, then we'll lock in for 30 minutes, and then we'll get out of there real quick. So save. Now I'm going to open up this view, and then we'll get started. Let's go to our here. All right, how you guys doing today on the live stream? I think I can look and see if there's anybody joining. Hopefully you guys are doing well. What we're going to be doing here is going over some practice questions for step 1. And we're going to be locking in for about 3 hours, right? So hopefully you guys have some things you'd like to review. And if you do, then just go ahead and put them in the chat. And hopefully I'll be able to see them soon. All right. So I figured I'd start with my OBS screen here. Got the bottom line. Okay. Just finalizing last minute touches here. All right, so the first question that we're going to do is on agammaglobulinemia. All right, so the pathophysiology of agammaglobulinemia. And I'm going to go over here to my sheet I've got. Welcome to the live stream here. And I've typed out 30 questions, basic ideas I'd like to get started on. And I'm going to run a timer as well so that we can take questions right after that. So here's our first practice question. I'm going to drag over here. And I'm just going to go on OBS to make sure this all works. All right, and the AI images are going to be updating soon with each new question that generates. And so I'm just getting all this set up. And next time, this will be just ready, lock and loaded, ready to go. So here's our first question. And I should zoom up a little bit so we can't clearly see the answer yet. But we have a 7-month-old boy. He's got a history of multiple episodes of pneumonia. So I'm going to zoom in here. All right, and otitis media since birth, and he has had diarrhea after a recent polio infection. Physical exam shows no tonsillar tissue. Lab studies show reveal markedly decreased levels of immunoglobulins and absence of circulating B cells. Okay, so now they're going to be asking us, which of the following is the most likely diagnosis? And we have to know the difference between all of these. Okay, so X-linked agammaglobulinemia. Usually they're going to evaluate this with the size and charge differences, right? Because electrophoresis, that's what it tells us is the differences in the size and the charge. And so common variable immunodeficiency, selective IgA, and severe combined immunodeficiency. So the first one I want to kind of knock off this list here is severe combined autoimmune deficiency. That's the boy in the bubble syndrome, right? So that's the person who always has tons of infections immediately. They literally have to live in the bubble for them to be okay. And So that's not going to be our answer. Selective IgA deficiency. So IgA deficiency is most common, but that's often asymptomatic. But you have a risk of like anaphylaxis, and they'll test you on blood transfusions there. And hyper IgM, this one's kind of easy because you're always going to see, well, elevated IgM antibodies here. Essentially, antibody deficiencies, you're always going to have some sort of a bacterial reinfection. Okay, so bacterial reinfection will always occur. And usually they're going to be with encapsulated organisms whenever it's hypogammaglobulinemia. And each disorder has its own different age of onset, and it has its own immunological pattern. And so the first one that we should really dive into is Bruton's agammaglobulinemia. That's the X-linked syndrome, which is the correct answer for this question. And I really got to pull up the chats somehow so I can kind of see if you guys have questions. But essentially, you have a mutation in the BTK gene, and that prevents the B cell maturation. All right, so we have to know that mutation pattern is BTK. And I'm going to make this a little bit bigger so you guys can see this. All right, so you have a BTK mutation. And you have absent B cells, and typically they'll say something like he has like no tonsils, and this will be about 6 months after you have the maternal IgG is going to start to diminish. And the pathophysiology is that there are no mature B cells, and all of the IgSs, like they're all down. All these guys, they're down, right? And so you have recurrent otitis pneumonia, you got diarrhea, and usually it's going to be in a male. And so all of these are kind of met by our practice question, and that's the reason why it's the answer. What about this one? Common variable immunodeficiency. All right, so that one is defective B cell differentiation, and that's going to be later. Okay, so CVID, variable immunodeficiency, is later. All right, so agammaglobulinemia is going to be immediately, but common variable deficiency is going to be like in teens or adults. And there you have the recurrent sinopulmonary infections, and you have the low immunoglobulins. But here, what you have is a normal B count. Okay, normal B count. So the age is going to be a huge differentiating factor in A. Let's see if there's a. Oh, it looks like I can see my Twitch chat, but I can't quite see yet the. I can't see the YouTube chats. Okay. So next we have hyper IgM, and we kind of talked about that one. We see elevated IgM spike for sure, and so that we can kind of eliminate that one pretty easily. And then the only other thing to think about is this IgA deficiency is typically going to present with some sort. It could be any age, and it's going to present with lower IgA, obviously, because it's deficient there, and celiac. Celiac is what you should think of this one, and maybe an autoimmune deficiency is what they'll have. They'll have anaphylaxis with a blood transfusion, and so that's going to be B. All right, so here is the kind of the lay of the land here. They've got recurrent bacterial infections, absence of tonsils, and low IgG across the board. All right, so that's the first question I wanted to cover, and then there was another one here. Okay, so this condition is, I have the three letters written out, and I want to see if you can guess what this condition is just by me telling you that it's an intellectual disability. Okay, so what condition do you think that this is? I'll give you a couple seconds. All right, so this is Leishman, and we have to know the pathway for this one. All right, so I'm going to pull this up real quick. So Leishman syndrome is going to be distinguished from other things like we talked about severe combined immunodeficiency. That's going to be a problem with the adenosine pathway. But Leishman, here, I'll bring that one up again. All right. So this is in your purine metabolism pathway. And there's a big, very important deficiency that you have to know for this one, and it is HGPRT. All right, so I'll do a practice question on this one, and I'm going to pull that over to the screen so we can all see it together. And with this one, you have gout, you have hyperuricemia, and retardation, right? So that's the intellectual defect. Got to make sure this countdown is going well. All right, so here's our question. I'm going to zoom it on over here. There it is. All right, so here we have a 6-year-old boy. He's brought to the clinic with evaluation of aggressive behavior. His parents report that he frequently bites his lips and fingers until they bleed, and he has involuntary writhing movements of his arms and his legs. Lab studies reveal elevated serum uric acid, and urine sample shows orange crystals. Which of the following enzyme deficiencies is most likely responsible for his condition? All right, so this is our big giveaway right here is our mental retardation and also that uricemia and also this self-mutilation. So anytime you see self-mutilation, literally just pick this within seconds and you should be good to go. So there's a leishmanian. Adenosine deaminase, that's the deficiency they're trying to get you to think of with severe combined autoimmune deficiency. That's just kind of, you got to lock down that factoid. Hyperuricemia and leishmanian and self-mutilation is treated with xanthine oxidase inhibitors. And also, so like allopurinol and phoebostat, and you do that so you can reduce how much uric acid there is. All right, so now we're going to do our next question here, and this one's going to be about kidney injury. So let me just pop this one up. And while I'm loading this one, I'll zoom on over. I want to talk about compartment syndrome. Okay, so compartment syndrome is associated with two things: necrosis of the muscle and also rhabdomyolysis. And so we're going to be talking about that in this next question. And hopefully, for the first time in this live stream, we will have, oh, and thank you so much. Looks like I can see it. Hey, good morning. Good morning. Thank you. Thank you. Okay, cool. I can see you guys' chats now. Hey, what's up, Jim? Musical singing Daniel. Hey, what's up? How's it going? Hopefully you guys are doing well. We got 21 more minutes of little questions, and we'll be kind of knocking this out really quickly soon. Sorry, it's been a little bit hiccupy with this first live stream, but we'll get really, really good at them over time. Okay, so right, the notes that I took, and I took these yesterday at my cousin's football game, by the way. So they're a little bit helter-skelter, and I'm hoping that they'll just improve over time. So next I want to talk about rhabdomyolysis, right, and how it's going to be tested. And fortunately, yes, my scripts were able to run, and check this out, guys. We have the AI images, and also we have the all the images that I wanted for this question. Okay, so I'm going to dive into this next one. Here's our question, all right? So this is the high yield question we have about, and let me know if you guys don't want to see these answers or if you like to see them on the screen. But here we have a 30-year-old woman, and you can actually see it over there. You can see her, and that's awesome. She presents to the emergency department with severe pain and swelling of her left forearm after a fall from the ladder. Upon examination, a fracture of the mid-shaft of the radius. Okay, that should already be telling us some things here. So this is a huge clue, and I would definitely highlight this in test day, and we'll talk about what that means, right? And she's got a fracture of a mid-shaft radius is detected, and the forearm is immobilized. 6 hours later, she reports worsening pain that's not relieved by analgesics, and she has numbness in her hand. Examination reveals a tense and swollen forearm. Blood work shows elevated creatine kinase. Urine analysis reveals a positive test for the blood, but no red blood cells are noted in microscopy. After surgical intervention, she develops reduced urine output. Which of the following is most likely the cause of her decreased renal function? All right, so do you guys have any thoughts about what this might be? And we'll break this down so it's like super, super simple. But the way that I see this is that there's this patient who fell and they sustained like some sort of a fracture, right? And they developed what's called compartment syndrome. And that's where I took the notes on this particular condition. That's when you have like tense, swollen limbs and there's severe pain that's out of proportion. It's like, whoa, why are you in so much pain? And then we get this thing called rhabdomyolysis, right? And do we know what rhabdomyolysis is? That is the destruction of the striated muscle cells, especially, they call it like, what do they call it? Azoturia, but it's the destruction of the muscle cells, right? You get, and sometimes you can have like abnormal nitrogen compounds in your urine, but it's the breakdown of muscle, right? And you release creatine kinase and also myoglobin, all right? Myoglobin. That's the red protein that contains the heme, right? That's myoglobin. And it stores the oxygen in the muscle cells, and so you get breakdown there. And the thing about and people don't teach this very well, in my opinion, myoglobin. I wish I could see all these emojis and things going on, but I'll get there soon. It'll be really fun. We'll be super interactive. Myoglobin, why does this matter, guys? Well, myoglobin matters because it's nephrotoxic. Myoglobin causes this condition that you should know for step 1 called ATN, which is acute tubular necrosis. And that leads to oliguria and acute kidney injury. Oliguria just means anytime you see oli, right? That means small, few. Oliguria is the production of abnormally small amounts of urine. All right, so what are we going to do about this question here? We got all these fancy kidney answers, and how do we distinguish between them? Okay, So we got this person, they fell, bad stuff, right? But we're thinking they have rhabdomyolysis from compartment syndrome. Hopefully, we all agree with that. And now myoglobinuria is identified by positive blood on the dipstick, but no, mark it, no, what does it not have? Red blood cells. Okay. Yeah, no red blood cells. And so myoglobin causes direct tubular toxicity and ischemic injury, and that leads to ATN, acute tubular necrosis. And because of that, we're thinking the answer is acute tubular necrosis. So you have to kind of go from rhabdomyolysis and compartment syndrome to ATN. Hopefully that makes sense. And I think I can see Jim's comments and then musical Dan's comments, but I don't know if I can see other people's. I'm worried that I'm missing them, but definitely, hopefully I can see them soon. Okay, what about this one? Acute glomerulonephritis. Okay, well, that would show with red blood cell casts. And there's also not myoglobinuria. So that's how acute is different. So that's the reason why A is not the right answer. How about B, hemolytic uremic syndrome? Okay, this guy, think of bloody kidneys, right? Microangiopathic hemolysis and thrombocytopenia. And thrombocytopenia is, of course, the deficiency in the platelets in the blood. And that causes the bleeding into the tissues and the bruising and the slow blood clotting after the injury. And that's usually post diarrhea. Okay, so there are a lot of things that tell us that this is not hemolytic uremia syndrome. And this step one is just a game of elimination, right? So eliminate HUS, eliminate acute glomerulonephritis. Hey, what's up? How's it going, Ken? Good to see you. And then we have drug-induced interstitial nephritis, right? That's where we have the eosinophils in the urine and the fever and the rash and recent medications is what you should think of for drug-induced, obviously, right? On UWorld, they love doing like drug-induced this. And every single time on UWorld, it's drug-induced. If you see that as an answer every time, right? So drug-induced interstitial nephritis would have eosinophils in the urine, fever, rash, recent medication. So think of like NSAIDs and penicillins. It's not seen in this answer. That's why it's not right. Okay, what about a nephrotic syndrome? Well, that's obviously heavy proteins, proteinuria. And so also you have like edema, hyperlipidemia, and you would not see this acute kind of renal failure. All right, so if the urine dipstick is positive for blood and there are no red blood cells on microscopy, then that's going to be myoglobin from rhabdomyolysis. And so here this patient just had a little fall. And they had compartment syndrome. And so the muscle is going to break down creatine kinase and myoglobin damages the renal tubules. Why? Because myoglobin is nephrotoxic. Okay, so that's like all there is to know. And I'm trying to think what else here. Basically, you just do a dipstick test, and you're like, oh, if it's got the hematuria, it's got blood there. There's free hemoglobin, myoglobin. You test for all those things, and if the dipstick and the red blood cells are present, then it's hematuria. If the dipstick but no red blood cells are present, then it's hemoglobinuria or myoglobinuria. And if it's trauma with increased elevated creatine kinase, then that's myoglobinuria. Oh, hey, how's it going? Man, everybody's from all over the world. Thanks so much. I'm so glad you guys are getting something out of this. And guys, if anything, my goal here is for the next 14 minutes, I just want you guys to have a place where you're like, I can't study anymore. Let's just get together and kind of commiserate and maybe learn some high yield facts along the way. All right, so this next one, I want to ask you guys about hemidesmosomes and what their implications are for step one, right? Because those are pretty high yield. They come up all the time, hemidesmosomes. And I have a mnemonic for this, which we'll kind of get into in a second. But anytime you see blisters and epidermolysis bullosa, then you should be thinking of the hemidesmosomes. So I'm going to get this practice question loaded for you guys so we can do this together. And I'm going to pop it right over here. Okay, hopefully you guys can see this. And I've just updated it with the new questions. And I'm going to scroll down so we can kind of see my notes that I took yesterday at my cousin's football game. And I'm going to also make myself a little bit smaller just so you can kind of see more of my notes. And go back here. Okay, so a 6-month-old girl is brought to the pediatrician with a history of frequent skin infections and poor wound healing. Her parents mentioned she has developed numerous blisters on her hands and feet shortly after birth, which have persisted. On examination, the patient had several areas of skin erosions with crusting, primarily the areas of minor trauma like her knees and elbows. Her nails appear dystrophic and mucosal surfaces are intact. Which of the following genetic abnormalities is most likely responsible for this patient's condition? Okay, All right, and then we got a lot of scary words here. All right, but we're gonna break these down just because there's a lot of numbers there. So collagen 1. Anytime you see collagen 1, a couple of buzzwords that come to your mind. The first one is osteogenesis imperfecta. That's the fractures, and the bile. The blue sclera, all that blue stuff in the eye. Anytime you see that, just think collagen 1. Also, you can see hearing loss too. So think of that. Fibrillin, mutations of fibrillin, that should make us think of Marfan syndrome. So I'll write this out for Marfan. Okay, so we know, and this is kind of a way that you can do this. Of course, it's good to have a robust understanding of all these medical concepts, but collagen 1, osteogenesis imperfecta, blue stuff, and the fractures. Fibrillin, Marfan syndrome. Tall, lens dislocation, aortic aneurysms, right? So really you can be super bubbly with that. And I've actually seen a Marfan's patient before. He had like an aortic dissection and he had a scar that looked like a shark attack. It was crazy. So collagen, all right, so collagen, and then they don't give us 1 because that's the easy one, but they give us collagen 7. Well, that one would have some scarring, some mucosal involvement, and it'd be like more severe. And then the other one they're giving us is collagen 4. Collagen 4 should make you just immediately think of Alport syndrome. And that is a renal disease, and it causes deafness and also ocular problems, okay? So we've gone through each of these, and we've been like, wait, I don't think that that's, associated with this kiddo here that we can kind of see over there in the AI image, our 6-month-old girl brought to the pediatrician. All right, so what is responsible for this patient's condition? Well, it's actually going to be a mutation in the keratin 5 and 14. We don't have to know about like the 5, 14 necessarily. What we do have to know is they have congenital blisters after the minor trauma and also the problems with the nails. Okay, so those are the giveaways, especially because they have intact mucosa. And so these are the features of epidermolysis, dystrophic nails, and intact mucosa. So it's going to be the epidermolysis bullosa complex. And so they've got mutations in the keratin. And that what happens is you weaken the basal keratinocytes and it causes intraepidermal blistering. Okay, so it's that blistering is kind of the giveaway here. Now, that is what we need to know about our hemidesmosomes. And there's one other high-yield note that I wanted to make on these guys. And feel free if you guys have any thoughts. I know I'm missing some of the chats in like the Twitch and the YouTube. Yeah, isn't it crazy? Jim, I'm so happy you're here. Thank you so much. Yeah, so many diseases and stuff, especially there's so many assumptions. Like, guys, anytime you see a strong dude who is like just like buff and like trying to succeed, he's on steroids. Every single time on step 1. So there are a lot of assumptions that you can't make in clinic, but you can make on step 1. And every male athlete is on steroids on this test. Kind of crazy. But yeah, hemidesmosomes, before we move on to the next one that I took notes on, hemidesmosomes, the function is the anchor, the basal keratinocytes, okay? That's like their role. And so I like to think of like the H, and I like to think that it's like anchoring them, okay? H anchors the keratinocytes. And so it's not important that you knew it was 5 and 14. What was important is that you knew that it was associated with keratinocytes. And the proteins involved are like the integrins, laminin, and all that good stuff. And the keratinocytes are the epidermal cells, which produce keratin, right? And so hemidesmosomes, you could think of H for half, right? They basically they're half of the connections. They connect the cells to the basement membrane, or you can think just keratinocytes. I don't know how you want to do it, but just know that, and then know epidermolysis bullosa complexes are caused by keratin 5 and 14, and that should give you all the points that you need on that particular question. Okay, so the next one that I took some notes on is constricted pericarditis. So what is constricted pericarditis? And I'm going to get everything loaded up for this question that I have here. So the big thing we should think of for this guy here is there's something that we see on examination with the patients. They're just sitting there, right? Yeah, this is our guy or our gal. And we look here and we see something interesting. Okay, so I'm going to go and pull up this next question. Just 1 second. And it's going to be changing the photos to resemble this next condition. Oh, I don't know if it changed yet. Looks like it's still the same. I have to fix that. Okay, so here is our question. And I'm going to see if I can get that right for the next one. Our 58-year-old man presents to the clinic with progressive fatigue and abdominal discomfort of the past several months. His medical history includes hypertension, and he takes lisinopril for it. On examination, he appears jaundiced, and there are significant ascites on abdominal palpation. Okay, what is this? What is this? Jugular venous distension is observed when the patient is seated at a 45-degree angle. Lab tests show reveal liver enzymes, and normal albumin levels. An abdominal ultrasound reveals enlarged liver and shows no signs of varices. Which of the following additional clinical findings is most likely to support a diagnosis of constrictive pericarditis rather than liver cirrhosis? Okay, so we have to know about like the pathophys of different conditions. Okay, slow read, a different way of thinking, pivotal, read the question sentence once, be able to solve it. Okay, yeah, I have many thoughts on that. Maybe one thing that you could do too is you could read, make sure you're reading the last question, the last part of the question first. I'm kind of narrating it backwards for how we take it on test day. But like here, you think, what do you need from this question? You need this, constrictive pericarditis, and you need this, liver cirrhosis. And then you have to distinguish between them. But then a bunch of buzzwords should come to your mind. It's kind of like, honestly, a pretty buzzy test, even though they test you on like the deep mechanics and mechanisms of action. And then from this, you should be thinking of Kussmaul sign. Right? Think of some conditions that are associated with these guys, right? Like, for instance, hepatomegaly, ascites, jaundice. And so anytime you see hepatosplenomegaly, or rather hepatomegaly, ascites and jaundice, you think of cirrhosis, right? And then also the right-sided heart failure and constrictive pericarditis can cause similar stuff. But Kussmaul's is how you distinguish between them, right? Because normally when you breathe, inspiration lowers your jugular venous pressure, right? You go, and now that is lower pressure over here. But if the right ventricle can't expand, it's funny. I went over here, even though it's the left side of my body, because I don't know. I always like invert them. The right ventricle. Because if I'm looking at a patient, it'd be the right side. It can't expand, and why? Because it's trapped by the stiff pericardium. Okay, so it's like trying to get up, but then you have pericarditis, and so you can't, and you get Kussmaul sign, because the jugular venous pressure is going to paradoxically rise. That's the hallmark, right? That's the hallmark of constrictive pericarditis. And thank you so much for saying the awesome style, Iqbal. Really appreciate it. Hopefully you're doing well. So yeah, Kussmaul sign is really the key differentiating factor. And that is why our answer is C. Okay, dilated intrahepatic bile ducts. What on earth is going on there? So dilated intrahepatic bile ducts, that would be what we call obstructive jaundice. Okay. Yeah, so that's not seen here. You'd have a whole bunch of jaundice there. And if you guys have any particular questions about like why there's jaundice, I don't want to harp on things that like are obvious, but I'm super happy to go into that stuff. Hepatic encephalopathy. What about that one? Well, that's a complication of cirrhosis from the ammonia buildup, right? Encephalopathy, definitely think of ammonia, okay? And this guy, pulmonary edema, that should immediately be a sign of cirrhosis for you. Why? Interestingly enough, it is estrogen excess, okay? Hyperammonia, again, liver failure, cirrhosis, that's what that's all about. Okay, and I did kind of hint on kind of like the dilated bile ducts causing the jaundice, and so I just wanted to kind of clear that up real quick before we move on to the next question. So yes, obstructive jaundice will cause like gallstones, maybe it's associated, gallstones cause obstructive jaundice, and then pancreatic cancer can cause it, and cholangiocarcinoma can cause it, and primary sclerosing cholangitis. A lot of things can cause jaundice, and the labs that you'll see is like elevated conjugated bilirubin, elevated alkaline phosphatase. You can also see the CGT elevated. Okay, so dark urine, pale stools, pruritus, jaundice, all that stuff. And on ultrasound, you see like a dilated extrahepatic duct. However, in constrictive pericarditis, you get congestive, what is it called? Like problems with your liver, hepatopathy, just like problems with your liver. So you have an enlarged liver. That's what it's just all big, right? Because it's congested, and you have increase in your LFTs, and you have ascites, and you have no dilated bile ducts, right? Because the bile flow has not been obstructed. Okay, that's the big takeaway. There's no problem with the bile. There's no jaundice because the bile flow is fine. Okay, the next question that I took some notes on yesterday that I wanted to talk about is the jejunum. All right, so what do we have to know that's high yield about the jejunum on test day? All right, so I have a question there. Thanks so much. I really appreciate it. Got to keep up the good vibes and the enthusiasm, or else we're all going to be drowning here. We're going to be like, oh my gosh, another step day. But thanks, Jim. Awesome. I really appreciate your feedback. I appreciate it, man. Okay, so diving into this one here. And hopefully I'm going to change these photos here so you guys can kind of see this next question that I have in the chamber for you guys. We're going to be talking about a 48-year-old woman undergoing abdominal. There it is. There she is. Okay, cool. And there's my dog Charlie in the background. He wants to be a part of the video. I'll have to join sometime. All right, so she is a 48-year-old woman, and she's undergoing an abdominal CT scan with oral contrast to investigate chronic diarrhea. The imaging reveals a distinct pattern in two different regions of the small intestine. Region A shows a pronounced feathery appearance, whereas region B shows a smoother appearance in contrast. Okay, what explains this contrast? Okay, so this is kind of like an easy one if you know it. If you don't, then it's like, what? What are you talking about? Jejunum ileum stuff, right? And so the two key facts we have to know is that on contrast imaging, okay, the jejunum looks like a feather. Why does it look like a feather? Okay, and I don't know if you guys have held a jejunum, but it kind of does. It's like all like, I don't know how to describe it, but when I held it for the first time, I was like, this looks freaking weird. Dense, tall, dense. It's got the like the pilicae, like the circular kind of structures, and that's just that it can absorb stuff, right? And in contrast, the ileum looks a lot different. The ileum is smooth like a baby porpoise, right? And so that appears smoother because its folds are lower and more sparse. Okay. And so like the lay of the land here is you give somebody oral contrast and it fills the small intestine, the mucosal folds. And, there are these structures that basically trap the contrast. And that's the reason why it looks all like sparse and like feathery. Okay, so it's the trapping of the contrast in the small mucosal folds. And basically, what they're testing you on here is that in the jejunum you have tall, dense folds, and it's feathery. But in the ileum, you don't have as many. All right, it's smooth. And so the smooth and distal vowel is ileum. And you remember the sequence by thinking DJ ileum, right? That's the chronology there. And so the taller structures are going to be the enhanced contrast pattern because jejunum is like all about absorption. If you go over to this guy's place, he's going to absorb you, okay? He's like all about absorption. That's why he has a tall fold, the long vasa recta, all that stuff, right? The ileum is more lymph tissue. That's the pear patches. That's what it's shorter vasa recta, right? It's not as much about absorption, and so you don't see as much feathery stuff. And I think we're that's a decent explanation. The tall plicae circularis is going to be associated with our more absorbative tissue, which is our jejunum. All right, so there we go. That's the practice question there, and those are the notes that I took on that question. So now we're going to dive into our next one, which is acute hemolytic anemia and the differences between warm and cold and Coombs test, because unfortunately we have to know those. And the spherocytes, right? Because we love our spherocytes. And let me just check on the Twitch, make sure that that's running. Okay, cool. We got on the Twitch here, and we got somebody over there. Awesome. All right, so our next question, screwed on over. Autoimmune. I took a lot of notes yesterday. I guess the football game was not going so crazy. Actually, what happened is we lost. Our home team lost by 1 point. And they lost on a blocked field goal kick, which is crazy. Anyways, it was a wild game. It ended at 11 p.m. And then I literally fell asleep making notes for this for this live stream. All right, here we go. Here's the next question. And I'll make sure that we have, looks like everything has just updated successfully. So here in this next question, we have a 72-year-old woman presenting to the emergency department with increased fatigue and jaundice. She has a history of rheumatoid arthritis, and her medications include methotrexate and prednisone. On examination, she appears pale and has scleral icterus. Lab studies show, whoa, look at all this stuff. We'll dive into that in a second. Okay, and now they're asking us, and I'm going to kind of zoom down here. And I'm actually just going to frame this so I can see exactly what you guys see with my red stuff. I made this this platform specifically so that it'd be really high yield information, and also so that I can see exactly what you guys see. So hopefully this will just keep improving. Okay, so what is the diagnosis? And we have all these labs. Okay, so it's very common to just see this and to just panic, and we have to be like, okay, what's the most important features that we have to know here? And I would say it's direct Coombs test, right? And so I took notes on this the other day. Direct Coombs test, Coombs just means you have antibodies on the red blood cells. That's all Coombs means. And it's big and scary, but that's it. Warm means that at body temperature, you have agglutination. And then cold means at lower temperatures, you have agglutination. And so lower is typically seen in like the periphery. Okay, it looks all big and scary, but that's what they're saying, right? So positive Coombs test is what I'd say is the most important part of this question. It means that you have autoimmune hemolysis. And that's associated with autoimmune diseases like rheumatoid arthritis and lupus and CLL. Okay, so actually I've written those down yesterday. CLL, lupus, and autoimmune hemolysis, right? So rheumatoid arthritis could be another one too. So I'll write that down, rheumatoid arthritis. So we have like an understanding of what this might be. And now they could ask us about the mechanism of each of these. They could ask us a whole bunch of things. But here, they might give us a blood smear. And let's say they do, and they give us this. What is this? It's a perfect circle. Kind of. It's a spherocyte, right? And we got to know how those are formed, right? And we got to know about this low hemoglobin and reticulocytosis, right? So all of these things we have to know. So the bone marrow will respond, and that's why you get the high reticulocytes. And then you have increased indirect bilirubin and increased LDH and decreased haptoglobin. And the spherocytes are occurring on the sphere. And then why is the reason that we get spherocytes? Anybody know? The reason we get spherocytes is because of partial phagocytosis of the antibody-coated red blood cell. That's the reason we get spherocytosis. And now haptoglobin, that is the protein that's present in the blood serum. And what it does is it binds and it removes the free hemoglobin from the bloodstream. All right, haptoglobin. All right, and I don't want to get too much in the weeds here, but the Coombs test tells us it's antibody mediated. And the spherocytes, it's like partial phagocytosis of the coated red blood cells. And so all of this is enough to tell us that this is autoimmune hemolytic anemia. Okay, and now I want to talk about the warm versus the cold. So the warm, right, is IgG. And the M looks like a snowflake, and so it's cold, right? So that's cold. M like a snowflake. G, go outside because it's warm, right? IgG. I should probably write that down as well. IgG is warm, so go outside because it's warm. IgM is cold, right? Because if you look at this, it's like a pentamer, and so it looks like a snowflake, so it's cold, okay? And hereditary spherocytosis, that's an autosomal dominant mutation, the spectrin, the ankyrin, and you have a negative Coombs test for hereditary spherocytosis. And that's why that's not your answer. How about this guy? Everybody loves choosing this guy for an answer. Okay, so this one right here is going to have the bite cells, the Heinz bodies, the oxidative stress. All right, so that's B. And then how about thrombotic thrombocytopenia purpura? All right. Hey, Asmita, thanks so much. I'm really glad you're enjoying it. More awesome videos to come. Hopefully you guys stick around and just get some enjoyment out of this. So really, I appreciate it. Thrombotic thrombocytopenia purpura. It's purpura. I don't know why I say purpura, but I've one of my friends was like getting mad at me for the way that I say that. So my apologies there. But TTP, for all of your guys' sakes, we'll just call it that. Thrombocytopenia is what you see with TTP. And I have a video on this, all the bleeding disorders, how to easily memorize them. But TTP is thrombocytopenia, neurologic changes, and schistocytes, and fever. Okay, so there's no, you don't really see those mechanisms here. And the big thing that we're not seeing are these neurologic changes for TTP. It's pretty severe disease. Okay, how about vitamin B12? Well, obviously that's macrocytic anemia. It's like the biggest thing we all know. And so no, that's not the answer. I think the hardest one here is hereditary spherocytosis, but that's Coombs negative, okay? That's like the hardest distractor question. So hopefully these are some decent kind of questions that are helping us orient. And looks like we just had we hit our first 30-minute deadline starting soon TM. So let me actually just go to that timer and fix that real quick. But in the meantime, if you guys have any questions, I'm going to put on a 5-minute timer so we can take a little break and you guys can stretch and get started here. And I'll answer any questions that you guys might have. Let me just go here and go to scripts, timer, and I'm going to set a 5-minute timer. And I'm going to do reset timer, close. All right. So we've just covered, how many questions has this been? We just covered 7 questions, okay? So hopefully we can get through like 50 here with full explanation, high yield concepts, everything you need to know. I'm just gonna go get a quick drink of water and I'll be right back in like 1 minute. So, and before I do that, I wanna check on the live streams real quick just to make sure they're all good. But if you guys have you wanna get up and stretch for a second, then I think that's a great idea. Just come back and ready to go. If you got something else to work on, just like 1 minute and we'll be right back. I don't think we're gonna take all 5. I'm just gonna check on the Twitch channel here. Yeah, on Twitch it says that I'm streaming Settlers of Catan, which I'm not. So I'm sure there's one guy like, hey, when are you going to play Catan? I'm like, oh. It also says yeah, I got to update my Twitch there. Okay, so edit, lock in live stream, tags, medical school. I'm going to change this to just chatting today. There we go. Medical content teaching. Okay. And done. Yes, Jim, I will publish this so we can all rewatch it. And I think I'm going to also just edit this for all the little ums and ahs, just so it's like super easy for you guys to rewatch. So I'll post it so you guys can just see it live. Or not live, but like the full thing unedited. The best way to go through the YouTube content is, guys, here's the way that I like to see it. I'm not like, I do this because I'm really passionate about medical sciences, and I think my video quality is going to improve over time. I want you guys to shop out, look at all of the YouTube videos that are out there, look at all the channels, decide what's like best and what vibes for you. And then leave a comment about what you like to see on my videos. But I would highly recommend, hey, Martha, musical singing Daniel. Martha, I didn't know you sang. You'll have to sing sometime. Good to see you. Good to see you. The best way to go through the content, I would feel, is to take the MBA, to go through UWorld, watch the like daily questions. They're going to improve over time. But then once you're in like the last month of prep, I want you guys to be going through the MBMEs, like solid going through them. And when I say go through the MBMEs, I mean like memorize every single wrong answer that you missed and all 4 or 5 of the distractor questions, right? And then I want you to watch the videos afterwards so you can like make sure that you're picking up on all the high yield notes. That's the best way to use these resources. I think it's really just in your best interest to go through UWorld like exclusively, just like tons of UWorld until you've got a 60% on like a full pass through. Once you've got a 60% on a full pass through, then take the MBMEs like crazy. Just churn them out. MBME. I'm talking like, guys, this is the most underestimated resource. Is like, everybody's like, oh, what questions bank should I use? What's the best way? The MBMEs literally just like, they're what other students were tested on in the prior years. And you have like 8 of them and they take a long time to review. As you can tell, we just did 7 and it was like 30 minutes. Right. And so I would really recommend that, Jim. I don't know if I answer your questions, but like watch the YouTube shorts just so you can like keep up with the content. I consider like the YouTube shorts that I throw out there as just like, okay, garbage points, right? Like low hanging fruit, or like sometimes they're esoteric, right? But really consider those to be like on key, right? All you're getting from the YouTube shorts is like a daily on key. Like that's how you should think of it. What the really meat of it is the MBME explanations. And I think that where it really comes in clutch is like after you've already studied and you can't do it anymore, you're like, please, no more studying. Then you turn on the video and you're like, okay, hopefully this guy is like jovial enough for like an hour to keep me entertained going over MBME explanations. That's the best way that I could say how to use it. Jim, let me know how I can improve my content so that it improves or like so that it scratches the itch that you're looking for. Because I'm all about that, but also like there are plenty of resources on YouTube, right? I'm just trying to put my voice out there because I think I can offer something unique in this space, but like shop around, do whatever feels right for you. You know yourself, you know how to study. And so I can't tell you like the best way to use the content, but that's like the lay of the land. Martha, really good to see you. Jim, thank you so much. I really appreciate that. Hasmita, can you plead the EP and MEPP concept? Definitely. I need some more. I need like a Google Docs, like a Google Forms where you guys can like put your recommendations. I'm happy to keep tailoring this however you guys would like. All right, so let's dive in again. I'm going to change this. Hold on one second. I'm going to change. Yeah, would it be good if I like scrolled up as well so we could see the key features? Would this be good? I think this would be helpful, right? The pathophysiology and that stuff. Yeah, I think that'd be a great idea. And let me just get a quick drink of water and then I will change this and we'll get dive back in. I have by the way, quick tip for residency or like interviews is don't drink water on camera. All right. Jim, you're so good. Don't worry about it at all. I love doing this. This is my huge water, right? And so I really recommend anybody getting like a huge, just freaking gallon of water. Because got to stay hydrated. None of us are. All right, let's do this. Let's dive right in here. I'm going to change the countdown again. And I just, this morning at like 7:30, I was figuring out how to use this countdown, so bear with me here. And we'll dive in and do another, hopefully we get 13 questions, and I'll go quicker. How's the pace, by the way? Should I go faster or slower? Should I speak more slowly? That's a common thing I hear. I just got so much to say. I want to just spit it all out. Okay, duration 30 minutes, timer, final text, reset timer, close. It's perfect. Hasmita, you're so nice. I love this YouTube channel because you guys are so nice. I posted like a video or like a photo of my car being crashed. And everybody was like, "Oh, I hope you're well. Hope you're doing good." And it was like, "Oh, thanks, guys." And then like all the comments are always so kind and positive. Um, oh yeah, the one-to-one tutoring sessions for USMLE. If you guys are feeling like you really just like need some extra juice or some extra energy in the tank and like you just can't do it, you can book a one-on-one tutoring session with me. Or I have a team of people from Harvard, Harvard medical graduate, like MDs from Harvard or current medical students at Harvard. And our rates are really good. They're $90 an hour, which of course is like higher than ACT tutoring typically. Like, you know, so I also have a tutoring company of like 30 Harvard employees that do ACT, SAT. And so that's $90 an hour as well. But for the same price for step one content, we also do tutoring. It's not required, obviously, but like if you guys want like a surefire way of passing this silly exam, then let me know. Also, like we give out a lot of scholarships too. Like our goal is not to like this is not how I make my money. Obviously. So like I just do this because I'm passionate about it. I love the medical sciences. I think like medical literacy is the most important thing we can do for our young nation. And so Martha, thank you for recommending that. And yes, we do have I think 4 students right now who are signed up, and we had 2 passes this last month. So really exciting stuff. And if you guys want tutoring, super happy to do it. I take on some clients myself, but also we have MDs from Harvard and medical students as well. All of them are from Harvard. We have 30 employees. Every single one is from Harvard. That's like our criteria, just because I'm really plugged into the network there. So yeah, if you guys want tutoring, then just fill out a form. I have no idea how to access this chat that you guys are like popping in from. I'm like seeing like all these like chats on Twitch and whatever. I don't even know how to respond, but it's ivtutoring.net and it's in the channel. And if you just fill out a form, then we have like automations that will run and it'll like onboard you guys. Martha, thanks so much, by the way. And I gotta listen to Michael singing Daniel. Like that sounds awesome. I don't know if you got like somebody who sings, but that's really cool. Okay, so let's dive in. To our next one, Manitol. Okay, and I came up with this last night. I thought it was pretty fun. I was at the game last night and I was like, Manitol, how could I describe Manitol? A magnet. Manitol is a magnet. And some of you guys are gonna be like, what are you talking about? And yeah, that's usually what people think when they talk to me. They're like, what are you on right now? Manitol, let me go to this question that I had ready to go. And let me kind of get everything loaded up here. Manitol is a magnet. Why do I think it's a magnet, guys? Anybody have an idea of, maybe I'm crazy. Maybe my mnemonic is just like insane. But what is the reason that Manitol is a magnet? Well, when we think of Manitol, we think of osmotically active substances, right? And so they raise the serum osmolality when you give it with an infusion. And by the way, if I have to look at some notes over here, it's just because I want to make this like super efficient for you guys. So basically, Manitol. Okay, so maybe the way to think about this is ADH and aquaporins is probably a good angle to take this in. But first of all, let me get the question so you guys know even what I'm talking about at all. So just bear with me here. I'm going to scroll down and I'm popping on the screen for you. And I've just updated the photos. Now I have to update these. Okay, sorry, 1 second. Let me just put this up here. This is doing my other question on ADH. So if you guys have any other quick thoughts here while I get this up. Okay. I'll move this over here so you guys can kind of see what I'm dealing with here. Here's our question. Unfortunately, got desynced because I did 2 questions here. But imagine this strapling older gentleman. He's only 50 something. He presents to the emergency department with confusion and severe headache following a head injury in a car accident. On examination, his blood pressure is 150/90. His heart rate is 88, and respiratory rate is 16. A CT scan of the head reveals signs of cerebral edema without hemorrhage. The patient is administered intravenous infusion of hypertonic saline. Which of the following changes in plasma sodium concentration and serum ADH levels is most likely to occur following this treatment? Okay. So here's our little question, and maybe I could like find a way to like put all these in the chat. Wouldn't that be cool if you guys could like read it in the chat yourself, and then maybe I could make like a PDF out of it or something like that? I think that'd be sick. Okay, just 1 second here. All right. So what's happening here is it's all about osmolality and ADH. And so if you have like some sort of, looks like this guy has like some sort of a traumatic brain injury. And what we're worried about is going to be cerebral edema. And that's whenever we raise the intracranial pressure. And so to counter this like extreme pressure increase in your brain, we have to give them did I write this? Hypertonic saline. An example of that is like 3% sodium chloride. And what that does is it just like sucks the water out of the brain tissues, and it relieves that pressure, right? Because you had a brain injury, you have all this edema, and you're like, oh my gosh, I have to relieve that somehow. You give them hypertonic solution, and it sucks all that out, right? So the saline, okay, so here's our answer, is increased plasma or sodium concentration and decreased ADH levels. But the way to think about this is that the saline raises the plasma sodium levels. And so the body senses that you have a hyperosmotic state, and it reacts by suppressing ADH. It's like, hey, we do not need ADH anymore, because ADH, what does it normally do? It normally holds onto the water. And now the body wants the opposite. It wants to flush it out and lower the concentration. And so if you have a hyperosmotic situation, then we're flushing it out, right? And so if you're thinking about increase the sodium, it would mean increasing ADH, then you should think again, right? Because there's no volume loss, there's no hemorrhaging, and there's no hypotension. And the blood pressure here is like what, 150? Yeah, 150 over 90. And so osmolality is what we need. We got to turn off that ADH, okay? So I want to explain this like super duper simply and not get super caught up on, what rises, what doesn't rise, or whatever. I want to like understand this intuitively. Basically, the body responds to hyperosmolar states through ADH. And if you have a TBI, so a traumatic brain injury, and you have cerebral edema, you have to give them a hyperosmotic solution so that the ADH can be tinkered in the proper way. So you increase the plasma osmolality, that's the primary trigger, and then you decrease the blood volume and the pressure, which is the secondary trigger, right? So that's the reason that our guy, the therapeutic effects will work on a dude with 150 over 90. All right, so just to explain this like super, super simple. We have a dude, swole up brain, car accident. To treat it, we give him a hyperosmolar solution, which is like, basically it's like just a very salty IV, is the way to think about it. And then the salt pulls the plasma, pulls the water out of his swollen brain, and that reduces the pressure. All right, and it also raises the sodium levels in his blood. And so what does the body do in response to that? That's what this question is asking. And I know it's like, this can be a confusing question, but that's what they're getting at. It's like, you raise the sodium levels in his blood, and what does the body do in response? Well, what normally triggers ADH, that's released when your body is too salty, right? Or when you've lost blood volume, right? That's what normally triggers it. The body's like, oh my gosh, hold on to that water. But in this case, he's not bleeding, right? So the blood pressure is normal. Well, 150 or 90, but his sodium is rising from the IV. And so the blood gets saltier and saltier and saltier and saltier. And then the body's like, oh my gosh, that's too salty. And it stops releasing ADH. And then to get rid of the extra water, it just lets it go, and it brings the salt levels back down. Okay. So the hypertonic saline raises sodium, and the high sodium causes the ADH to drop. All right. So that's the lay of the land there. And so Manitol is the substance they like to test you on this, and it's an osmotically active carbohydrate monomer. And so it raises the serum osmolality when it's given in an infusion. So mannitol is a hyperosmol, and so it's a magnet. Mannitol magnet. And then so it just basically like sucks things up and helps with the edema. That's the way to think about it. Okay, cool. On to our next question. I want to see what I took notes on for this next one. I think it was, oh, right, the hepatitis stuff. All right. Let me pull up the hepatitis stuff here. On to my next little question. And I'm thinking about in the future, I'm going to have like rotating images. So I want to have like, you see at this bottom, those three, I want to have like slowly rotating or something like that. I think that'd be really cool. Okay, so our next question, let me pop it up for you here. Is right here. Okay. Hopefully you guys can all see this. A 25-year-old woman presents to the emergency department with a 5-day history of fatigue, low-grade fever, dark urine. She recently returned to a camping trip from Southeast Asia, where she indulged in various local dishes, including sushi and street food. She denies any history of intravenous drug use and recent sexual encounters. On physical examination, she reveals jaundice and tenderness in the right upper quadrant. Lab studies show elevated liver enzymes, AST, ALT, significantly increased. Which of the following is most likely the cause of her symptoms? Okay, so This one is an interesting question. Okay, so hepatitis A, travel food. Hepatitis B, the bedroom one, right? So sex and blood, bedroom. And hepatitis C is drug use, so drug IV. And Epstein's-Barr virus would be transmitted with saliva. Okay, so here we got a woman, and she's presenting with acute hepatitis, and we got to figure out what it is, but it's most likely viral, right? And that's based on the short timeline, because what was it, like 5 days? Yeah. So she's got 5 days, and she's got jaundice, she's got transaminase elevation, and she traveled to Southeast Asia. And now she's consuming all this raw contaminated food, and there's also like not risk factors for this bloodborne disease. And so all this points toward a fecal oral virus that's most commonly going to be hepatitis A, right? And so hepatitis A here and hepatitis E, these are both acute, they're fecal oral, and they're travel associated. Hepatitis B, on the other hand, this one is usually chronic, and it's blood or sexual transmission. And then CMV could be another answer here. Cytomegalovirus or leptospira is less common, and it's typically involving immunocompromised hosts, right? Yeah, exactly. Good, Nathaniel. So leptospirosis would not be acute as well. Those would involve, like, the way to think about leptospirosis is it's less common and involved in immunocompromised individuals, or you have to have like a specific exposure pattern to it. And so here, what we see in this person is dark urine. So that tells us that maybe there's like some conjugated bilirubin that's spilling into the urine. And there's jaundice, so there's hyperbilirubinemia from the liver dysfunction. And then there's like tender right upper quadrant pain. What's that about? Well, that's the liver capsule, right? And then there's the camping and the street food. All that suggests that it's probably A or E. And so leptospira is also like a good one to analyze. And so let's talk about why directly that's wrong. Well, that one would require fresh water exposure. And usually, Nathaniel, who asked this, it's animal urine. And so that typically also has renal involvement. And so you have conjunctival suffusion as well, or some sort of a hemorrhage. Okay, so that's leptospira. Does that make sense, Nathaniel? That's the reason why it's not that as our answer, because anytime it'll be like some animal urine in the fresh water, or like they're swimming in a lake or something like that. Yeah, really good question though, because I can tell you're thinking about it the right way. But yeah, that one's pretty buzzy. But so on step one, leptospira, it's like the way they ask this is like it's tropical, or like they do like rural travel, but then you contact with flood water. They love asking this about flood water or mud or lakes and rivers, fever, jaundice, and then you definitely have to have renal involvement though, and like the red eyes. And so that's going to be in clusters after hurricanes or monsoon rains. But yeah, that's the way that they ask it, I guess, is the best way to kind of explain that. So other thing is like the incubation timeline occurs with leptospira is a little bit different. Like it's usually like 7 to 14 days. And so the symptoms of onset are like, it's going to be sudden and acute. You're right. But it's often biphasic too. So like the leptospira has an acute phase. That's where you have the fever, the chills, the myalgia, and the headache. And then you have an immune phase. And that's like really severe with leptospira. So it's like jaundice, renal failure, conjunctival suffusion. And that is known as like some disease. It's like whale disease or something like that. Right. But that's beyond the scope of step one. Really great question though. I like it because you're thinking about it the right way. Really good question. I love this. This is so fun that we get to talk about all this cool medical content and stuff. So that's awesome. It is not Hep B. The answer, because Hep B is similar to Hep A, but it's typically more severe in pregnant women is how they would test you on this. And she does not look prego to me. And so I would not say that the answer is E here. The answer is indeed hepatitis A virus, right? CMV is gonna be a good one for immunocompromised people, like mild asymptomatic and healthy individuals. Hepatitis B, blood, sex, perinatal. That's what you think of for hepatitis B. Hepatitis A is our correct answer here. This is just like fecal oral transmission, and we talked about leptospira. So hopefully that's helpful. And then I want to see if this works. Ready? Oh, almost. It almost worked. Let me just make sure. There we go. Oh, I need to fix that. 1 second. There we go. I have 3 cameras, by the way. I want to show you the other one here. Video capture device. Add. Boom. Okay. That's the other scene. So if we need to do like and that's why you always leave a note. I'm just kidding. I don't know. If we need to have like a serious moment, then I can always flip on over to that. I think this is going to be fun in the future, guys. We're going to have a lot of fun together doing this. Let me just, see if I can get this working. Oh, that could be cool. Let's do this. There we go. So anytime I click this button now, it's going to be like, and that's why. And then here we have our bottom line. Hepatitis A is most likely the cause. And I don't know where to put this guy. Is most likely the cause of acute hepatitis in travelers with recent exposure to contaminated food and water. Tony, thank you so much. Tony, I love that this is a good community for all of us. Guys, I'm so bad at making Discords. Hopefully I can get the Discord running and we can all like hop in together and be like, wow, do you love step 1? I love step 1. Do you love I love it too. Just kidding. I don't know what you guys are going to talk about in that Discord chat. But hopefully it's a good place you can all just like, I don't know, crash out together and have a good time. Okay, so on to our next couple of questions here. Let me just not run out of RAM on my computer. I got a lot of processes running. By the way, I just purchased these guys right here so I can make more content for you guys. Check it out. I just purchased, this is a MacBook M4, fully maxed out, fully spec'd out. And I'm actually using this full time to run AI content and videos. And so this guy right here, I'm going to be plugging downstairs and building a server out of so I can do cloud functions. So by the way, like I have a background in computer science from Harvard. And so that's why I'm like super passionate about like the medical field. It needs to change, right? Don't you guys feel like we need to be super powered by like artificial intelligence? And so that's why I've been coding, and soon I'm going to have a bunch of really cool content for you guys. I've been just like coding nonstop, trying to get some awesome video generators, Sora 2, all this stuff so that I can give like the most high yield fun content. Because let's be honest, this kind of sucks sometimes, right? So, all right, I'm digressing a lot. I'm getting derailed. Sorry about that, guys. Let's lock in. This is a lock in live stream, not a crash out live stream. We'll have one of those soon where we can just like complain about the state of the world. Just all sign in and be like, oh my gosh. All right, so on to the next one. Okay, yeah, 3 hours of study accountability. Sorry about that. We're gonna keep us accountable over here. So going on to our next one, and it is we are going to be covering ADHD. Okay, which I clearly have. So I can tell you guys a lot about this one. So ADHD. The fidgeting, the careless mistakes, and typically you don't have like the neurological signs for this one. And so there's also decline in academics, right? That's actually required for diagnosis these days. So let me just pull this one up for you. And I want to make sure I'm doing this right for Hasmita. There we go. Okay. So there's our practice question. And there's our kiddo. So I think this is fun, right? This is cool because we got our person over there. We can see like the breakdown. You can see like what organ is associated with it. You can see the practice question. You see the bottom line. We can go over here. We can go over here. Whoa. It's kind of fun, right? And these streams are just going to get better over time. So thank you guys so much for joining. I love that you guys are spending your Saturday hanging out with me, learning some step 1 questions. Hopefully it's a good like way to stay rejuvenated and learn a lot. All right. So we have a 9-year-old girl is brought to the pediatric clinic by her mother due to concerns about her behavior at home and school, sorry. The mother notes that her daughter frequently loses her possessions and fails to follow through on her instructions and often makes careless mistakes of her homework. Additionally, she has difficulty remaining seated in her class, frequently fidgeting and often blurts out answers before questions are completed. Physical examination reveals signs of physical and neurological abnormalities. Her academic performance last year has declined. If pharmacotherapy is considered, which of the following mechanisms of action is the most likely the best, most beneficial? Okay. So really kind of for all these side questions, we just have to know about the timeline. And once we know the timeline, we're usually pretty good to go. And we have to know like some basic stuff about diagnosing the condition. And so here, this is just classic ADHD, right? Especially in a young girl. Are you kidding me? Yeah. And so the most effective treatment is actually going to be stimulants, right? Stimulants are what we give to these kiddos. And sometimes it can actually cause them to not eat, but then they have rebound hyperphagia later on, right? Because like Adderall, for instance, will suppress your appetite because you're like, oh, I'm fine. I feel satiated. But then afterwards, you have hyperphagia rebound. Anyways, thought that was interesting. I spoke to a physician the other day, a pediatrician, and we were discussing that. But anyways, yeah, so stimulants like methylphenidate, amphetamines, right? That boosts the dopamine and norepinephrine in where? Where does it boost it? Anybody know? The prefrontal cortex. Right. And so that corrects the neurotransmitter deficiency. And because essentially what ADHD is a neurotransmitter deficiency, and it improves attention and impulse control. Okay. How about this one? This is a really important question to be able to understand in and out. Acetylcholinesterase inhibition. Okay. Acetylcholinesterase. That one is used in Alzheimer's disease, not ADHD. Okay, what about 5-HT? Okay, so inhibiting 5-HT and norepinephrine uptake, well, that would be the job of an SNRI. Okay, that's like venlafaxine, and it's used in depression and anxiety. It's not first-line ADHD. All right, what about, I'm going to zoom in here so we can kind of clear up our screen. By the way, I purchased this software that's infinite scroll. I hope you guys like it. I think it's kind of fun. We can just like pretend that we're on Man in Black for a second there. So calcium control, that's seen with gabapentin, pregabalin, and that's used for seizures and neuropathic pain, right? Gabapentin for the calcium channels. How about potentiation of GABA? Okay. That would be like benzos or Barb's like sedative, and that's not helpful in ADHD. Okay, so that's kind of an easy question, but bottom line here is benefits from synaptic dopamine and norepinephrine concentrations. Having fun with it. All right, moving on to our next question that I took some notes over. And oh my gosh, did it just restart the timer? Oh well, looks like we're going for another 30. So I'm gonna zoom out and go to my next question on barbiturates. Okay, barbiturates, right? Barbiturates is the most important concept that we have to know for this one. So let me just get this set up. Okay, so hypoventilation. What does hypoventilation do to your AA gradient? So that's what we have to know for this one. And basically, alveolar ventilation and gas exchange can change depending on if you have like CNS depressants or benzodiazepines or barbiturates. Okay, so I've just generated this next question with this dude over here in the corner, and we're going to talk about his gradients. So here we go. All right. So here we have a 45-year-old man is found unconscious at home by his partner. He reports that he was using an unfamiliar medication prescribed for severe insomnia. On arrival, he is somnolent and minimally responsive to verbal stimuli. Vital signs show respiratory rate of 6 breaths per minute and blood pressure of 110/70. Heart rate of 88 beats per minute. Oxygen sat is 85% on room air. Patient is intubated for airway protection. Arterial blood gas is performed. Okay, so these tell us like a tremendous amount of information about different conditions that he could be suffering from. Okay, so basically we got a 45-year-old. He's unconscious, right? He's barely breathing. That's important. Hardly breathing at all. His respiratory rate is 6. That's the reason why I say that. He's hypoxic. How do we know he's hypoxic? Look at that. SpO2, 85%. He's hypoxic, right? And if you want, we can talk about like what that means, the hypoxemia of 85%. But the most likely cause is sedative or hypnotic overdose, right? And that is like benzodiazepines, barbiturates. That's what causes that. So there's respiratory depression and there's hypoventilation. And so obviously hypoventilation causes less oxygen to be brought in. And so the CO2 is going to build up in the blood. And since the lungs themselves are totally normal, then our AA gradient is going to be normal. And yesterday I was like, typing this up, but yeah, it's going to be normal. Okay. So somnolence, low respiratory rate. He's only at 6 per minute. So that's central respiratory depression. The PaCO2 is elevated. So that's hypoventilation, and the PaO2 is hypoxia from low ventilation, and there's a normal AA gradient, right? And so you have like opioids, benzodiazepines, barbiturates, drugs, central respiratory depression, right? There's low PaO2, high PaCO2. So let's dive into these answer choices. It looks like a good choice. Our PaO2 is going to be lower than normal, so lower than normal and maybe lower. And then PaCO2 is going to be higher than normal, so our answer is going to be B. And our AA gradient is going to be relatively normal. Because what is your AA gradient, by the way? That increases if there is, and I wrote this out yesterday, a VQ mismatch, right? So a pulmonary embolism or like pneumonia. And you have diffusion defects, right? So maybe a diffusion defect would be like fibrosis. You got some fibrosis going on there. Or it could be like a right to left shunt, like a cyanotic heart defect. And so the pathophysiology is the sedative overdose, lower respiratory drive, hypoventilation, there's less O2, and the alveolar capacity is going to be intact, right? So ABG shows respiratory acidosis, but the AA gradient is normal, okay? So you have sedation, minimal arousability, and lower respiratory rates, and there's PaCO2 is going to be elevated, the PaO2 is low, and then there's alpha gradient AA gradient that's normal. that's pretty much all there is to say about this, right? But there are some questions about like, what is the hypoxic? Like I wish that somebody would have taught me this earlier on in my medical education. So SpO2 of 85, what does that even mean, right? You're like, okay, cool. Well, that is the peripheral oxygen saturation. Okay, that's what you measure with a pulse oximeter. Like the finger clip that they put on. I actually just recently got an O-ring. O-ring. Have you guys seen this? Recently got this. But things like this, I can tell you your peripheral oxygen saturation, right? That tells you how much oxygen is bound to hemoglobin in the blood. Okay, so normally your SpO2 is going to be around like 95%. That means that almost all of your hemoglobin is carrying oxygen, some sort of oxygen, right? And so SpO2 of 85 tells us that 85% of the hemoglobin is carrying oxygen. That's not a lot. And so they're hypoxic, right? Which basically means there's not enough oxygen in their blood. And so what causes the low SpO2, hypoxia, is a couple of things. 3 things I want you to think about. 1, hypoventilation, not breathing enough, right? 2, lung problems, pneumonia, pulmonary embolism. 3, high altitude, right? Less oxygen in the air. And then 4, I guess would be another one, shunting or a VQ mismatch. And so here, SpO2, she's not getting enough oxygen into the blood because of the slow breathing. That's what's happening, but different conditions can cause that. All right, and then maybe it's worth mentioning diffusion. I mentioned diffusion and fibrosis. Well, the core idea there is fibrosis thickens the alveolar capillary membranes, right? And so this allows, or rather, this slows down the diffusion of gases, especially O2. All right, so it slows down those diffusions to cross. And so basically, fibrosis, as we mentioned, is a thickening of the alveolar wall. And so if you have like idiopathic pulmonary fibrosis or like collagen or scar tissue, and it's building up between the alveoli and the capillaries, that makes it really hard and slower for oxygen to pass through. And so it's a diffusion problem, right? So oxygen can't diffuse. And so that causes the lower PaO2, and diffusion is much faster than O2, right? I mean, CO2 diffuses much faster than O2. Like CO2 diffuses like 20 times faster, by the way. And so PaCO2 can stay normal, or it's only slightly going to rise, but PaO2 drops because the oxygen cannot cross effectively. All right, so we kind of beat that to death. Basically, the bottom line, respiratory depression from sedative overdose leads to hypoxemia and hypercapnia, evidence in elevated PaCO2 and low PaO2. All right, there we go. And then here's another VO2, which maybe we could use it at some point. All right, on to our next question. And then I have to reset that timer because it looks like it's set at 29. Or did it do it again? Maybe I just checked and it just like randomly did it again. Okay. So our next question is on osteoarthritis. And there are 3 things that you need to know for osteoarthritis. Well, maybe a little bit more, but like for step 1, these are the 3 big ones, right? 1 is it's a wear and tear disease. 2 is that it involves joint space narrowing. And by the way, the answer to this last one was indeed B. All right. And then 3, it worsens with activity. And that's like very distinct, right? It worsens with activity. Okay, so this is loaded now. So we have our new question. And I'm going to show you guys the practice question. Let's see if you can get it. All right. A 70-year-old man, as you can see here in the corner, presents to the clinic with chronic pain of his lower left hip that has progressively worsened over the past year. He describes the pain as dull and aching and worsening with prolonged walking and standing and improving. Let me check the time here. We're good. And improving with rest. On a physical examination, there is decreased range of motion on his left hip, but no signs of swelling and erythema. A hip x-ray reveals joint space narrowing, osteophyte formation, and subchondral sclerosis. So already based on these like 3 things that I told you, you're like locking in that this is osteoarthritis, right? It's like very clear. But they give us like appearance, they give us leukocytes, they give us neutrophils, and also glucose. And so the pathophysiology here is that we have this dude. He's older, right? Because aging does this. Aging, he's got joint stress, he's got cartilage breakdown, and there's the bone that attempts repair. So there's like osteocyte like formation, and there's joint space narrowing. Why is there joint space narrowing? All right, it's because the cartilage itself is lost, and so you get joint space narrowing, right? Because you have less of the cartilage. And there's also subchondral bone that thickens, and that's called sclerosis. And so the joint then becomes like stiff and painful. That's the pathophysiology. And so oftentimes, and I'll scroll up so you can kind of see these key features right here. Large weight-bearing joints, the joint stiffness, the synovial fluid, the x-ray has joint space narrowing. All of these things point to osteoarthritis, right? And so you treat this with exercise, NSAIDs, and weight loss as well. Yeah, because obesity is one of these mechanisms. And so previous joint trauma would really indicate that this is the condition we're dealing with. Okay, so here's our bottom line. Osteoarthritis, and I'm going to throw this guy away for a second. Osteoarthritis is characterized by joint space narrowing, osteophytes, and clear synovial fluid with a low leukocyte count. And I wanted to hit on the clear synovial fluid here real quick. And so we'll hit on that one. And the clear synovial fluid, we'll talk about that. And then, oh, we got a question in the chat. If osteoarthritis is degenerative diagnosis and non-inflammatory, why do we treat it with anti-inflammatory drugs? Ooh, that's a good question there. All right. Yeah, that's a really good question. So let's break this down. You're right. Osteoarthritis is indeed degenerative. It's not autoimmune. So yes, you're right about that. So there's cartilage breakdown from wear and tear, and there's no autoimmune attack with like for instance, like it's not like lupus or rheumatoid arthritis. So it's that's why it's called non-inflammatory arthritis. But big but here, local inflammation does occur. So as cartilage, okay, so as the cartilage breaks down, the debris accumulates where? In the joint. Okay. And then that triggers mild inflammation in the synovium, right? And so that synovium, so like we have inflammation. And like that's the long short of it, right? So you have cytokines, you have like TNF alpha, you got like IL-1. And so the synovium is that like the thin, soft connective tissue membrane that lines the inner surface of your joints, right? So that's where you get the inflammation. And so you have TNF alpha is elevated, IL-1 is elevated, you get the pain and all the swelling and stuff. And so inflammation is not the cause of osteoarthritis, but it contributes to the pain and the stiffness, especially after you have flare-ups through osteoarthritis. And NSAIDs, what do? Well, they target the symptoms, not the disease itself. So you give them naproxen, you give them ibuprofen, and it reduces the joint pain and the mild swelling, and you get and like the morning stiffness, right? It does not, however, and MD Ray, thank you for pointing this out. This is a really good point. It does not stop the cartilage breakdown. It does not slow the disease progression. So I think I may have said treatment, but it treats the symptoms, right? And so it's used for comfort and function, but not cure, right? Not the cure. Really, really good question. Hopefully that's a good answer for you, which gets into like these different kind of conditions. Like osteoarthritis is mechanical wear, so cartilage loss, and you have symptomatic relief of mild inflammation and pain. But then rheumatoid arthritis is more of like an autoimmune condition, right? And that's where you have autoimmune inflammation of the synovium. And a core part of the anti-inflammatory and immunosuppressive therapy is going to be NSAIDs for rheumatoid arthritis. But old age, occasional aching, and some inflammation, treat the symptoms with NSAIDs. Yep. Okay, hopefully that was good. And hopefully that answered your question. Thank you so much for asking. That's always fun. I love the engagement. This is a good time. For this next one, I'm going to try out something different. Actually, here it is. 15. Okay. Oh, no, not that 15. 14. Yeah. Okay. So, let's say you're looking at a patient like beep, 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 beep. All right. And then they're going to ask you, hey, what part here has the smallest stroke volume? What do you guys think it would be? What is the part that is most has the smallest stroke volume? Okay, so obviously it's going to be this weird part, right? The stroke volume is the difference between the ventricle and the end diastolic volume. And so if you have a shorter diastolic filling time, then you have a shorter stroke volume. And that's all there is to know about this one, right? Oh, we got another question here. Weight bearing. Yes, you got it. Yeah. Nitish, hopefully I said your name right. Yes, it's the one with this. Yeah, nailed it. Okay, so weight bearing, joints mostly implicated, why hands and wrist? Could you clarify that question really quick for me? I just want to make sure that like I fully understand what you're saying. But like why the hands? Well, like the distal joints, right? That's commonly affected in osteoarthritis. So osteoarthritis, let's look at our loading. We have our distal joints. Just going back to this question real quick. So like in osteoarthritis, basically it's the high use is to answer your question, MD Ray. It's like you're typing all the time like me, you're gripping, you're writing, you're lifting. All of that involves repetitive micro motions, and that causes cumulative cartilage wear in like the knees and the hips, right? And so this is like an age-caused disease as well. So that's the reason why you see it. Also, you have genetic predispositions because there's this thing called nodal osteoarthritis, right? And that's in the hands of like a familial pattern, especially in women. And it's associated with like the Heberden nodes and the Bouchard's nodes. And so like the reason why is, okay, cool. I decided your question. Don't want to go on too much of a rabbit hole here, but like, yeah, I think you're asking about like the DIPs, right? And like the PIPs, right? Is that kind of the question? So the DIPs, the distal interphalangeals, these are like the Heberden nodes, right? That's closest to the fingernail. And then the PIP is the Bouchard's nodes, and that's like the middle joints, right? And so that's like the proximal stuff. And then the MCPs, those are spared in osteoarthritis, right? They're involved in rheumatoid arthritis instead. And it's because of the like osteoarthritis in the wrist, that's uncommon. Because if there's wrist pain that's dominant, you should think of a post-traumatic osteoarthritis, like some sort of old fracture, or like inflammatory arthritis. Okay. So yeah, hopefully that answers the question. And yes, you nailed it. Yeah, Natish got it right. Definitely this one. And it's all about end diastolic, like the filling times, because of the startling mechanisms at play, right? Because if you have more fluid in your heart, then you can pump it out more, right? So it's simple there. And yeah, we're making up the lost time here by kind of going more quickly for these questions. So really good question, MD Ray. I love this. I love getting the dialogue going, and it's just like, ooh, osteoarthritis. Why is it this? Why is it that? Super fun. Okay, so let's load this next question, shall we? And we'll be talking about a healthy 19-year-old. And so let's just lock this in. Hopefully you guys can still see my notes. These, the fishy cells. Okay, I love this one. Get a clue. Throwback. A long time ago when I was at Harvard, we played Clue every single week. And I had a friend who guessed the right person and the suspect and the room on like the second turn. It was insane. Then we calculated the odds of that, and we're like, what? You were cheating. You had to be cheating. Statistically likely, you had to be cheating. But all this to say clue. How does this clue tie into this next question? Well, here it is, folks. I've loaded it for you. A 23-year-old female, as you can see over here, presents to her primary care physician with a 4-day history of malodorous vaginal discharge. She reports no itching or pain, but the odor becomes more noticeable after intercourse. She is sexually active with one partner and uses oral contraceptive pills. A speculum exam reveals a thin, grayish vaginal discharge. Okay, we already should know the answer. What is it? If you guys know the answer, let me know. Microscopy of the discharge mixed with saline shows epithelial borders. What is that? Oh, what is this? This is so buzzy, guys. A whiff test is performed. Oh my gosh, we're all on the tip of our seats. We're saying this is bacterial vaginosis. Yes, bacterial vaginosis. And that's how it feels on test day, right? You're gonna be like, oh, it's on the tip of my tongue. I have to know this. And really just locking in these high yield conditions is what's going to get you these points. So basically, 23-year-old, sexually active, malodorous vaginal discharge. There's no pain or itching, right? So the symptoms are worse after intercourse. But the big giveaway is that thin gray stuff, and also the epithelial. Anytime you see the word epithelial in the context of like the stuff, yep, clue cells. You nailed it, MD Ray. You nailed it. You're thinking about the clue cells, right? Get a clue. So if something smells fishy, get a clue. All right, because you're like, oh, something smells fishy. I need to get a clue to understand what's happening here. Anyways, positive whiff test, fishy odor with the potassium oxide, the KOH, the fishy odor with the KOH, right? That's the clue test. That's the whiff test for the clue. So something smells fishy. Look for those clue cells. And so this is going to be bacterial vaginosis. That's the only thing you have to memorize is bacterial vaginosis. And there's one more thing that I wrote down as well, like the Gardnerella species. So BV goes with GV. That's the way you remember that one. Okay, so I said a lot of things here, and I was like looking around here. So BV, GV. So remember those go together. BV, GV. And then remember, something smells fishy, get a clue. Hey, Sloan, what's up? Good to see you. Oh, it's awesome to see you there. And MD Ray, you're batting 1,000, man. MD Ray has got his stuff down. So yeah, Gardnerella vaginosis is an anaerobic gram variable rod, and so it causes disruption of the lactobacillus dominated flora. And so that occurs after you give them antibiotics. Typing over my old notes there. Or a new sexual partner, right? And that can increase the risk of like preterm labor or pelvic inflammatory disease if this goes untreated, right? So the pathophysiology is you have normal vaginal flora, lactobacilli, and then you have an overgrowth of the anaerobic bacteria like Gardnerella, and then the anaerobes produce the amines and the fish odor, right? And then the bacteria adheres to those epithelial cells, and that's the reason why, folks, we get my favorite board game, Clue. Which is also, the funny thing about Clue is that it's a solved game, right? So bacterial vaginosis is characterized by a thin grayish discharge from a positive whiff. And, but yeah, Clue is actually a solved game, by the way. All my friends, we started taking notes and we realized, oh, it's just a math problem. Like you know, once you've calculated like some basic information, you just keep track of everybody's guesses and then you figure it out. And it was no longer fun for anybody. But that's a clue, okay? This is bacterial vaginosis. This is Gardnerella. And that's all you need to know for this question here. So now I'm going to be loading up our next question. And I think I have, yep, question 16, guys. We're doing great. Okay. So on to our next one. Let's see if I can get, oh, I don't know if the image changed. All right, 45-year-old man. It's okay. We'll have to bear with me on the image. Sometimes it doesn't change, I guess. 45-year-old man presents to the emergency department after a fall with a ladder painting in his house. He landed on his left elbow, which is now swollen and painful. On examination, there is decreased sensation of the medial one and the half fingers of his left hand, okay? And the patient also complains of difficulty in certain hand movements, suspecting the ulnar nerve injury. Which of the following movements is most likely impaired in this patient? Okay, interesting. And let me pull up the chat just so I can see if you guys are saying anything. Okay. So what's happening here? What's going on? Basically, we have some sort of a medial problem. There's trauma to the medial epicondyle, right? And if there's trauma to the medial epicondyle, then we're usually going to think of an ulnar injury. And an ulnar injury causes the loss of the interosseous muscles, which causes the abduction of the fingers, right? The abduction and the adduction of the fingers. That's the ulnar. And we know that because the medial epicondyle is going to be what's damaged there. And so the medial two lumbricals are also going to be affected, and there's sensory loss of the medial hand. Right, so the key features of those medial 1 to 1.5 fingers that have the sensory loss, and then there's injury at the elbow, and there's a loss of the finger abduction, and hypothenar wasting is also possible. Okay, so basically the ulnar nerve innervates the dorsal interosseae, which abducts the fingers like this. It also innervates the palmar interosseous. That's the adduction, right? So palmar interosseous. Ready? I'm going to use it. Ready? Palmar interosseous. Dorsal interosseous. Palmar. Dorsal, palmar, dorsal, palmar, dorsal. I can't even say, it's like a tongue twister. And so the sensory loss occurs over the medial 1 and 1/2 finger, and it's difficult with these movements. And so you have an ulnar nerve injury. Okay. How about flexion of the thumb? What about that one? What about this? Okay, flexure of the thumb, that'd be the median nerve, the flexor pollicis longus and the brevis, right? Flexor pollicis longus, brevis, and that's the median nerve. Okay, what about the pronation of the forearm? So remember soup, if you want soup, you put your hand like you want a soup, and then you want to pronate it, right? And so pronation of the forearm, that's the median nerve through the pronator, teres, and the quadratus. Okay, what about the flexion of the wrist? Like this. Doop, doop, doop. That's the flexicarpi radialis, that's the median nerve, and it does most, and the ulnar, it does the flexicarpi ulnaris. But yeah, here we're talking about the interosseous stuff, so it's not the answer. How about supination of the forearm? You want some soup, right? That's the radial nerve, the supinator. That's the muscocutaneous nerve for the biceps as well. So I saw a question the other day. It was like against resistance of the biceps, right? And we just have to know that the radial nerve, the supinator, and the muscocutaneous nerve does the biceps. Hopefully that makes sense. If you have any questions about that one, let me know. But the ulnar nerve impairs abduction of the fingers due to weakness of the interosseous muscles. And that's the most important thing that you should know for this question. And I got to find something to do with this view. Like, hello. Hi, how's it going? This is my setup, by the way. And if you guys ever like and subscribe, it's crazy what happens is this will change colors. And I want to show you an example of this. So if you guys click subscribe, this is what happens. See? Isn't that cool? And then I'm making it as well so that if there's like a follow on Twitch, this is what happens. Ready? It turns blue. Woo! And then back here, it's kind of messy, but I don't know if you can see, that's my diploma there. And I can change the color as well and turn it on to red or to blue. So all these things are actually configured. So all these things are configured so that if you guys like and subscribe to the channel, it changes the lights in my room, which I think is kind of crazy and fun. Okay, so on to our next question. And the next question we have here is going to be, let me check my notes. I took a lot of notes the other day. Question 17 is going to be this one right here. Okay, there it is. So we have a 25-year-old woman presenting to the clinic with a sudden onset difficulty breathing and right-sided chest pain after a vigorous game of tennis. She denies any recent trauma or previous respiratory issues. Her past medical history is unremarkable. On examination, her respiratory rate is 28 per minute and her heart rate is 115. Her blood pressure is 110/70. And she's using accessory muscles for respiration, and her oxygen saturation is 93% Roumare. Auscultation reveals diminished breath sounds on the right side, which the following findings are most likely observed: percussion of the right hemothorax. Okay. So there are a couple of things that are super high yield to know for identifying the breath sounds. And let me just cancel out of some tabs before my computer crashes. So we got some tennis, right? You got sudden dyspnea and pleuritic chest pain in a healthy young adult. Okay, so if they're healthy, they're young, they're feeling fine, and they just have some dyspnea, all of a sudden it's spontaneous, right? Spontaneous pneumothorax. And that doesn't help us, right? There's no actual answer that says spontaneous pneumothorax. Oh, wow. Look at that. Okay. Omar is too good. Omar is just like too good. Guys, what should we do about Omar? He's obviously ahead of the game. Yes, there's error in the pleural space, and that causes hyperresonance on percussion, right? Because if you have like air, and then it's going to be hyperresonant, right? So there's decreased breath sounds, right? The lay of the land here, just to be really simple, because obviously you guys kind of know this one here. 25-year-old, sudden shortness of breath, right-sided chest pain, no trauma, tachypnea, tachycardia, and accessory muscles. That's going to be breath sounds on the right. That's going to be spontaneous pneumothorax every single time. Ruptured subpleural bleb, right? That can occur in healthy people, and usually they're going to be tall as well. So really, on test day, the buzzwords you think of are sudden onset pleuritic chest pain. Okay, if there's sudden onset pleuritic chest pain, then there's going to be an air leak. Okay, that's what that means. And diminished breath sounds on one side, that's the air or the fluid in the pleural space. And then the young, healthy stuff, that's spontaneous. And then the hyperresonance tells you that there's air in the pleural space. Yeah, look at Omar, man. He's rocking it. Omar's going to take the test this Saturday. That's what he told me. Just kidding. But maybe. So really, this is interesting because here it's a woman, right? Normally, a way that I've seen this tested is there'll be tall, thin adults like me, but like actually thin. I'm 6'5". I don't know if it looks like I am or not, but thin. And I'm like 260, so probably like, I don't know, like 170. Activities on rapid pressure with shifts, like, tennis, or they're like diving, or they're like flying. I don't know. They're doing something active like basketball. And there's a rupture of the subpleural bleb. And so air enters into that pleural space. And that progresses to a tension pneumothorax if it's not treated, right? So the alveolar bleb, air is in the pleural cavity, right? Air displaces the lung tissues, and the lung tissues go inward, right? And then there's a loss of the negative pleural pressure, and so it collapses. So you lose that pressure, and it will collapse that part of the lung, and then the air in the pleural space acts as a barrier to sound and vibration. Okay, so hyperresonant percussion on the affected side, and then there's decreased breath sounds and decreased fremitus, and the X-ray shows visible pleural line and the absence of lung mucking, so there's risk of tension pneumothorax. All right, so here's the long short of it. Boom. Hyperresonant percussion indicates pneumothorax in young patients with sudden respiratory depression and diminished breath sounds. Nice. Doing great. Okay, so here's this next question here. Going over to question 18. This one, ventilation. Let me switch on over so you guys can see the screen. We need to talk about cerebral vasoconstriction. Okay, so what are the implications of it, and also intracranial pressure? You can see here in my other view, and I go back to this other one here. Ooh, that one's fun. There we go. Okay, just generated the new image, and we have our patient here. There. All right. We have a 28-year-old woman admitted to the intensive care unit after being found unresponsive at home. She has a history of severe headache for the past 3 days. On examination, she is in a deep coma with a Glasgow coma score of 5. Her right pupil is fixed and dilated, while the left pupil is reactive to light. There is reflexive extension of the left side and painful stimuli. Her blood pressure is 180 over 100, and pulse is 52. A CT scan of the brain demonstrates large right-sided epidural. Hey, what's up? Hey, Justin, Chris, how you doing? A CT scan demonstrates large right-sided epidural hematoma and significant brain compression and midline shift. The decision is made to hyperventilate the patient mechanically. What is the primary physiologic reason for utilizing hyperventilation in this clinical setting? Okay, wow. This is This is a good little question. And what are we doing here? We are just going to do, I think, 15 more questions, right, guys? Maybe around 15 or so. We're going over some high yield USMLE, just some free points for you. That's our goal, right? Okay, so we got some crazy stuff happening here. The brain is swelling dangerously, and you've heard time is tissue, right? And so we're midway through this question here. Okay, Omar. Oh, guys, Omar is too good. Yeah, the brain is swelling, right? And so basically, a young woman is in a coma. She's got a blown pupil and a midline shift of the massive epidural hematoma, and so she's herniating, and that is life threatening. And so what do we do, Omar? How do we solve this? Reduce ICP through vasoconstriction. Bing, bing, bing. You got it, right? So what we do is we lower the CO2 causing vasoconstriction, right? And then that shrinks the cerebral blood volume and that lowers the pressure inside of the skull. Okay, so usually people are like, oh, what about oxygen? What about cardiac output? What about autoregulation? Well, it's all about cerebral vasoconstriction, right? Yeah, but you got it. I knew you. Yeah, you're good. And so that's why your answer is D, right? Does that make sense? Do you guys have any questions about that? Basically, hyperventilation, right? You're breathing a lot. Like my dog after a 3-mile run. He's like, lowers the PA of CO2, okay? And that causes cerebral vasoconstriction because CO2 likes to keep things open in the brain. And that surprises people at first. It's like kind of a weird thing. But therefore, you'll lower the intracranial pressure. Okay, so you're reducing the cerebral blood volume because of vasoconstriction. And so you're lowering the intracranial pressure. And that is super important in the context of uncal herniation from an epidural hematoma. And so that buys us more time before surgery. That's like what it does, right? Let's talk about the other answers because it's really important. And I think one of the things I try to do on my channel is dive into the details of every other explanation. I want you guys to thoroughly know in and out what's right, what's wrong, right? So improved arterial oxygenation. Well, the oxygenation is not the issue, right? The patient likely already has normal PaO2. Okay, that's interesting, huh? Hey, thanks. Dude, I love your vibes, Jessen. How do you say your name, by the way? Is it Jessen? Jessen Chris? Chris Jessen. Thank you. I love your vibes, and I'm glad that you're here with us today. So improving arterial oxygenation, right? Oxygenation is not the problem here, folks. This person already has normal PaO2, okay? How about this one? Induce systemic vasodilation. Well, vasodilation increases cerebral blood volume. And so what's that going to do to the intracranial pressure? It's going to worsen it. Don't do that, right? No, don't do that. Okay, preserve cerebral autoregulation. Well, autoregulation is often lost in acute brain injury, right? And so, no, that's not what we're going to be doing here. And indeed, like Omar said, the answer is D. How about reduced cardiac output? That's not the target here, right? And so, what they love to do, what the USMLE just loves, they love this. They're like, okay, we got this problem. It's related to oxygen, and so the answer has to be the heart, has to be the lungs. No, it's just about vasoconstriction because of intracranial pressures, because of that uncal herniation. Okay, that's the way to think about this type of question. And so the bottom line is hyperventilation causes cerebral vasoconstriction, reducing intracranial pressure in the case of an epidural hematoma. Okay, and I want to talk about an epidural hematoma because that's like crazy high yield. And hopefully we can get through all these questions. What time is it? Because I'm actually meeting with 2 other potential hires for tutoring at 11 a.m. So we got some time. But we plan on going through all 50 of these questions. That's the goal, right? 50 of them. We'll analyze them fully in depth. Whoa, it just switched me over to this view. I have no idea why. That was crazy. That was insane, guys. Wow. Anyways, let's see what's happening here. There we go. All right, so I did want to talk about an epidural real quick, if there's time here, because that's actually super important. But maybe we can do that after this question loads. So the next question that we're talking about is 19. Let me scroll over and see my notes. 19. Okay. All right, here's the next question, and hopefully everything has been loaded properly. We'll see in a second. Boom. Yes. 37-year-old man. Yeah, you are. Yeah, you're going to be good at Dr. Sunday, Justin. That's awesome. How old are you, Justin? I'm curious. Are you in medical school? All right. Because this is kind of a channel. I'm super happy you're on board. This is awesome. All right. So 37-year-old man is evaluated during primary care for chronic lower back pain and persistent anxiety. He has been taking a muscle relaxant and antidepressant for the past 8 years, prescribed by a previous physician. He reports he's feeling good, but becomes exceptionally anxious about possible side effects whenever any medication changes are suggested. Despite reassurance during visits, he frequently contacts the clinic with questions that have already been addressed, often expressing concern about medication interactions and adverse effects. Medical history shows hypertension, gastroesophageal reflux disease, both well managed, and he appears well groomed. 23, nice, that's awesome. Are you in med school too? He appears well groomed and cooperative, but nervous. His vitals are stable. With recent lab workout, is unremarkable. Which of the following is the most appropriate approach to making this care more efficient? Okay, what does this person have? And we have to assume some stuff in this question, right? But what has he got? Do you guys know? So he's coming, he's joining, and reassurance is not going to be enough for this guy, right? Is a 37-year-old man, right? Yeah, so 37, chronic back pain, persistent anxiety about medications, frequently calling you all the time. He's got your number on speed dial, and he's stable. He's well-groomed. He's fine. But you're reassuring him, and he's not. It's probably not going to go away. And so how do we help this? Excuse me. How do we make the care most efficient? Well, he's got health-related anxiety. It's like not hypochondriac per se, but they're overutilizing clinical resources and they're just wanting reassurance, right? Maybe there's even like an aspect of OCD here, but they would benefit from predictable, structured follow-up, clear communication about when to call, and written and established protocols for contacting the providers. You have to stick to that, right? So you got to create boundaries and be predictable. Okay, so the answer is schedule regular follow-up visits and establish a protocol for the timing. All right, and so here's the bottom line here. Bottom line, you guys can all kind of see here. Address health-related anxiety with cognitive behavioral therapy to improve the patient's care, efficacy, and reduce unnecessary clinical interactions. Your goal is to help them with their problems, but also do it in a boundary kind of driven way. Right? Yes. Natish says boundaries, please. I would appreciate that too, wouldn't you? Natish, if you're cool with this, just put your phone number in the chat and we'll hit you up every hour of the day, and you reassure us every single time we text you. No. Yeah. Boundaries, please. Right. And maybe next time I can have my green screen up so that we can like put my head over this person. I don't know why. I like to do that. I think it's kind of funny. But yes, ADP is our next question, what we're going to be talking about. And here's our question. I'm going to scroll down so we can see this. And hopefully just maybe don't take a peek at this answer yet. There it is. I'm going to hide the answer for you. How's that? Okay. And so here's the next question. We're on question 20. Okay. So good job. You got that one right. Natish got it right. And so here is our question. 40-year-old man has a history of hypertension and is controlled with lisinopril, and it presents to a research laboratory volunteering for a study on platelet function. His complete blood count is normal, and he has no history of bleeding or thrombotic events. As part of the study, his blood is drawn into sodium citrate tubes, and a platelet-rich plasma is prepared for analysis using optical platelet aggregometry. Of the following agents, which is most likely to result in marked and permanent increase in the light transmittance in this assay? Okay. Whew. So imagine this. You're 180 questions in and you see this. You see this beast of a question. And you have to be kind of in the headspace to just break this down methodically and know the pathophysiology. I think that's a really good place to start. By the way, I want to check is my camera good? Good. So what happens here really quickly is there's ADP and it's released from the platelet granules. All right. Option. How'd you know? How'd you know it was option D? You nailed it. Jeez, you guys are so good. Yes, and I did kind of mention ADP is released from the platelets, right? And so that binds. Where does this bind? It binds. Anybody know? Yep. Yeah, you nailed it. Super good. All right, so ADP binds to P2Y12 receptor, and where is that located? On the platelet surface itself. Okay. And so then this activates your GP2B3A receptors. And then fibrinogen does this cross-linking thing, and that's like irreversible aggregation. And then the plasma starts to clear, and the light transaminase increases permanently. Okay, that's the pathophysiology here. And so the buzzwords are, we're measuring the light through the plasma, and like ADP is super important. That's an irreversible platelet aggregator through this receptor. You have to know this and this, right? You have to know these. They go together like two birds in a feather. And permanent increase in the light transmittance, that means the platelets are clumping and there's clear plasma, right? Okay. And I want to explain this like even more simple afterwards, because this is kind of like a memorization question, to be honest. But the key takeaway here is in optical platelet aggregometry, more aggregation, like if you're aggregating a lot, then more light passes through. And ADP is a potent platelet agonist. And so it causes that aggregation we talked about, and it's permanent. And so it increases the light, right? And so in healthy volunteers, if they're doing this test, basically they have the platelet-rich plasma that's placed in a tube, and you get an agonist like ADP, or another answer could be like thrombin, and that's added, and that causes the platelets to aggregate. And then the plasma becomes clear because light is passing through it more easily. And that's the functional platelet test, right? That's kind of what's happening here. Let's look at these other answers and why they're wrong. Okay, serotonin, what's that all about? Well, that would be a weak platelet agonist, right? Minimal aggregation. How about epinephrine? Well, epinephrine can cause transient aggregation, but it's not always irreversible, so no. Von Willebrand factor. I have a brother in medical school as well, and his name is Brandon, and so I call him Von Willebrand, which I think is funny. That promotes adhesion, not aggregation, okay? Von Willebrand is an adhesion molecule, not aggregation. Very important. How about thromboxane A2 right here? Okay, so that is a strong activator in vivo, but it's unstable in vitro. And so it's not typically going to be used here. Okay, so that's how we measure how sticky platelets are, the stickiness measure. We measure the stickiness by the light that passes through. And ADP is super special because it's irreversible aggregation. And once those platelets link via this GP2B3A, they stay clumped and the plasma stays clear. That is why ADP gives us a permanent increase in the light. All right, so we're just measuring how the platelets aggregate. And ADP is a natural chemical that tells them to aggregate. And it causes the strong and permanent aggregation. And so then the plasma clears up and light transaminase goes way up, and whoop-de-doo, you're having a good time. Now, adhesion versus aggregation is high yield in this exam, so it's probably worth just like briefly touching on. I didn't make this test. They did. They want you to study this stuff for 7 hours. I'm just along for the ride. Aggregation. All right, so plug formation, right? Adhesion is when the platelets stick. So here's your damaged wall right here. Can you see me? Okay. Your platelets stick to the damaged wall. That's adhesion. Aggregation is when this platelet that has stuck sticks to another guy, and another guy, and another guy, and another guy. They're aggregating to each other. So platelet adhesion is the first step where the platelets bind to the exposed subendothelial collagen that's damaged. And the key molecules there for the adhesion are von Willebrand factor that acts like glue. Ooh, 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 stuck like glue, you and me, baby. Yeah, right? So von Willebrand. And that one uses the GP1B receptor on the platelets. And that binds to von Willebrand factor. Without von Willebrand factor or GP1B, the platelets can't stick. They can't stick to this wall that I have up here. Okay. And the disorders associated with that are von Willebrand's disease and Bernard-Soulier syndrome. Von Willebrand's is obviously defective von Willebrand. Bernard-Soulier is a defective GP1B. And so both of them are adhesion problems. Platelet problems, on the other hand, the platelets clump together to form the plug. And the key molecules there are GP2B3A, fibrinogen, and fibrinogen links. Here, I'll write this out. If you go over here. That's what it links right there. So it links GP2A and GP2B3A to the platelets. That's what it does. Okay, and this is triggered by a couple of things. One of them, Jess and Chris mentioned, is ADP, right? Also, this one, you may have heard of it, TXA2 and thrombin, right? And so Glanzmann's is going to be a defective GB2B3A. So this is going to be Glanzmann's. All right. That's a lot of stuff we just covered there. Yeah. So like aggregation, the lab triggers are going to be ADP, thrombin, epinephrine, and it causes increased light transamination or transmittance rather. And adhesion is von Willebrand's and collagen, and you don't really measure that through light transmittance. Light transmittance is measuring your aggregation. Okay, there we go. There's the bottom line. All you need to know about your ATP stuff here. Next one, we're going to talk about some placentas and how the baby is born or not born in some conditions. And so we're going to move on to question 21. 21? Right here. Okay. So let me just go right on this way. And there we go. There we go again. All right. So the placenta. We got to talk about the placenta. One of my friends in the Harvard chess team would always talk like that. So anytime I introduce a new topic, I'm like, the placenta. Here we go. Boom. Got everything set up. And I'm going to move myself over here. And by the way, let me know if you guys like this this kind of setup here, or what you guys are thinking about. Do you guys like the way this looks, or should I move anything over to the left or the right side? Let me know, because I'd be happy to tailor things to your guys' liking. Oh my gosh, Jess and Chris, you're from Twitch. Hey, welcome. That's awesome. I didn't realize you guys were probably like, who's Jess and Chris? He's from Twitch, guys. Hey, welcome, man. That's awesome. Okay, so now we're gonna lock back in, and we're gonna do platelet aggregation. Oh, we already did that. Oh, we're gonna do the placenta. Sorry, I let you guys see it. I let you sneak peek at the answer. Hopefully you guys didn't see that answer there. Okay, sorry, I was just checking on the live streams for a second. Hey, Justin, that's awesome. Welcome. On the Twitch channel, we also play a lot of games too. But today we're doing medical content for some reason. All right, so here we go. Placenta. So here we have a 33-year-old woman presenting for her first prenatal visit at 10 weeks gestation. And I'm going to cancel out Twitch because I'm getting distracted by seeing myself there. All right. She has a history of 2 prior cesarean deliveries, 4 fetal distress at term. Her current pregnancy has been without complications so far, and a recent ultrasound showed a single live intrauterine pregnancy. At 38 weeks, she undergoes a scheduled cesarean delivery. During the operation, there is difficulty in separating the placenta from the uterine wall, leading to significant hemorrhaging. A uterine artery embolization is performed to control the bleeding. What is the most likely cause of severe bleeding in this patient? Ooh, that's a good one. I wonder, Justin, do you know this one? I'm really impressed with your medical knowledge at this point. You and Omar and everybody, you guys are like killing it. Okay, so let's talk about this one. Placenta. Yeah, how do you know this stuff? Are you in medical school? Or are you like a doctor? That's amazing. Good job. You nailed it. And so let's talk about this. Like placenta accreta. That is when the placenta grows directly into the myometrium without the decidua layer, right? And that's strongly associated with prior C-sections. And so it's difficulty separating the placenta with massive hemorrhaging, right? How about this one? Option A. Well, that's going to be the cause of postpartum hemorrhaging, but it occurs after normal placental delivery, right? So there we have a boggy, the word they like to say is like the boggy uterus, right? How about this one? Uterine rupture. Okay, so that actually presents with a sudden pain and fetal heart problems. And so there's like a loss of, what would it be? Like a loss of station during labor, and it's not a placental separation. Yes, good. Man, okay, Brahmdeep, welcome. Oh, I remember Dr. Brahmdeep Singh. Awesome, good to see you here in the chat. You guys are nailing this, really, really good stuff. Placenta previa, that's when the placenta covers the cervical os. So if you're like looking down, maybe that's not the most appropriate way to kind of explain this, but you know what I mean, the cervical os, and it causes the painless antepartum bleeding, and it's not retaining the placenta at delivery, right? So D, placenta accreta is our correct answer. Good job, everybody. You guys nailed that one. And the placental products there. So usually the retained placental products, like the small pieces left behind at postpartum, but not the entire placenta would be stuck to the wall, right? And so that's why the answer is not going to be E for this one. Okay. So really just explaining the pathophysiology pretty simply here. Prior uterine surgery damages the decidua bacillus, and the placenta villi abnormally attaches to the myometrium without an intervening layer. That's the big part, like without a layer. It's like going on a run without socks. I don't know. The placenta can't separate normally at delivery. And so you have to go in there and remove it manually. It's life-threatening, right? That's the pathophysiology. That's what's happening here. And there are risk factors. What are the risk factors? Previous C-section. Okay? They're going to say like Gravata 3, Para 2. Previous C-section, placenta previa, and uterine surgery. Those are the risk factors. By the way, guys, risk factors, so freaking high yield these days. Two of my friends recently took the STEP exam, and they both said risk factors. Risk factors, risk factors, risk factors. Okay, so know those forward and back. I'm going to make some more videos on this soon, but know them. How about placenta accreta? The villi attached directly to the myometrium there. No decidua, right? And then placenta increta, that's where the villi invade the myometrium. Okay, so like imagine like this. So placenta accreta, the villi attached directly to the myometrium. And there's no decidua. No decidua there, okay? And placenta accreta, the villi invade into the myometrium. They're inside, and that's why they call it increta, right? And placenta percreta, the villi penetrates through the serosa or the bladder, okay? So just kind of different levels here. Different levels, but know the risk factor. All right, so there's the bottom line. Severe bleeding after cesarean in this patient is most likely due to placenta accreta. So very good. You nailed that. Very impressed with you guys. This is insane. By the way, please let me know how I can improve this content. If you guys have any feedback on the community post, just let me know. Always trying to like do better and better and better. Okay, let's do this next question. 20. Oh, this is a good one, guys. This is a good one. I'm trying to think about the best way to kind of explain this. Oh, this is going to be a fun way. I'm going to write down some symptoms. Cough. Coryza. I got to look at my notes here. Conjunctivitis. And Koplik spots, okay? If I just tell you these, what are you thinking? Oh, thank you so much, Brahmdeep. I really appreciate it. I'm super happy that you're here. Welcome, and I hope your Saturday, hope all you guys' Saturday is just amazing. Thanks for spending your time with me today. I really enjoy it, and I honor that, and I'm really grateful for all of you guys here. Yes, MD Ray, Natish, measles, measles, measles. Yes, he nailed it. Cough, Coryza, conjunctivitis, and Koplik spots. Okay, good. I'm very, very pleased there. We got the measles, but let's just blitz through this practice question here because I want to see how they're going to present this on test day because they're not going to be so nice, right? They're not going to be as nice as me there. They're not going to just give you these 4 C's. But yeah, the prodromal fever, the cough, the Coryza, the Koplik spots, followed by 1 to 2 days of macular papular rash. I'm looking at my notes right now. I took on before this. Okay, yeah, giant cell pneumonia. Cool. So as you can see, in our nice little question here, we have a 6-year-old girl from a rural area, and she's brought to the clinic by her parents due to persistent cough and difficulty breathing over the past 4 days. Medical history is significant for congenital immunodeficiency that limits her ability to mount adequate immune responses. On examination, she's febrile and tachypnic, and crackles are heard through the body's lung fields. Her parents mentioned that 2 weeks ago, she had been in contact with a cousin who was recovering from febrile illness with a rash that started on the face and spread to the rest of the body. A chest x-ray reveals bilateral interstitial infiltrates. Lung biopsy is performed showing multinucleated giant cells. Which of the following viruses is most likely the cause of her symptoms? Okay, and we got a couple of answers here. And you guys already said the answer is measles, but can you tell me why? Brahmdeep, you nailed it. Why is this measles, though? Like, what's the giveaway? I know that we talked about buzzwords, but what's the pathophysiology? Like, how do we know this exactly? Okay, so measles virus infects the respiratory epithelium. And so in normal hosts, it causes coughing, coryza, conjunctivitis, and a rash. But in immunocompromised hosts, the rash can be mild or absent. And so the virus then, where does it go? Is like, oh, you're immunocompromised. I'm not going to deal with you anymore. No, it spreads to the lungs. And that causes what? Anybody know? Measles virus. I am late. Justin, what's up? Yes. What does that cause if they're immunocompromised? Giant cell pneumonia. Okay. Giant cell pneumonia is what it causes. And there's this fusion protein. What is that called? It's called F, fusion protein F. The synthesia and the multinucleated giant cells, right? And the way that I like to remember this, by the way, is the 4 C's. Everybody knows the 4 C's of measles, right? Measles. However, did you know the 5th C that looks like a G? Right? Doesn't it kind of look like? Yeah, I don't know. So giant cell pneumonia, it's going to be rare. You're not going to see this with measles, except in what? Immunocompromised patients. Okay. So if you see those like Koplik, the bright red spots in the blue-white center of the buccal mucosa, and it's followed by 1 to 2 days of macular papular rash, starts in the head and the neck, and it spreads downward, and there's lymphadenitis, all this stuff is going to tell you that this is measles. All right. And this is rubeola virus, measles, giant cell. That's what there is to it. Okay. So now let's talk about these other choices like adenovirus, and I'll scroll up so you guys can see the lay of the land. Would you guys prefer it if I zoomed up and you could see the pathophysiology and the features, or would you prefer it if you saw the answer choices? Jess, yes. 404 response not found. No immune system. That's funny. Oh man, I'm dying. Hey, check this out. Time to drink of my gallon of water. All right. Another good thing that's good for the gallon. I started taking creatine recently. There's some studies that they're starting to give this to elderly patients to prevent from like fall damage because it increases like the accessibility of ATP in your muscles. And so I've loved starting to use this. And so another great thing that I'd say, if you guys use creatine, pair it with a gallon. Okay, guys, like no sense in taking this, damaging your kidneys without like taking care of your, you gotta balance your osmolality, right? Make sure you're drinking water if you're taking creatine. And that's part of the reason I have my like gallon of water here. And I also have my dumbbells as well, so I can kind of work out intermittently. But I digress. And by the way, would you guys prefer if I showed the answer choices or prefer if I showed the pathophysiology so we can kind of see this? I don't know what you guys prefer, but it basically says the same thing that I said, right? Oh, viremia. I didn't mention that. So it spreads to the skin and the rash in the lungs. Yeah, an immunocompromised because of the T cell response that clears the virus for a self-limiting rash. Okay. Yeah. So if you guys like, I could put that up there. But we have the fever, cough, Coryza, conjunctivitis, and the giant cells, the Werthen cells. All right. So why is it not adenovirus, which is one of our there? Why is it not this one? I'll scroll down so we can kind of see this stuff. Okay. Adenovirus. Why is it not that one? Well, adenovirus that can cause the pneumonia, but this does not form what? Our fifth C. It does not form giant cells. Also, it lacks that rash. Okay, so that's why it's not A. Tony says pathophysiology. Tony got it. Yes, Tony's right, the pathophys. Respiratory. Okay, why is it not RSV? By the way, my brother almost died of RSV when he was young. Well, that causes bronchiolitis in infants, not giant cell pneumonia in older children. So really, it's the giant cell that gives this away. Measles is correct. Cytomegalovirus, why not that? Well, cytomegalovirus, one huge buzzy word that you would be seeing here, is that OWI inclusions. And this can affect the immunocompromised, but you would not, but you'd see those allied inclusions. And here we have the multinucleated cells. And so that's why it's not CMV. Okay. Varicella zoster virus, that can cause pneumonia, but it usually follows like some sort of a vesicular rash pattern, not like a measles-like pattern. Okay. So the bottom line here, multinucleated giant cells. Let me just zoom out because I'm too zoomed in. In recent measles exposure suggests measles virus as the cause of pneumonia. Okay. So that is the answer to our question. And Coryza, I want to talk briefly about that as well. Whoa. Things are going crazy over here. Yeah, so that Coryza is just a fancy medical term for inflammation of the nasal mucous membrane. And that leads to like runny nose, nasal congestion, and sneezing. And so it's basically what you experience with a common cold or an upper respiratory infection. That's what like Coryza is. So think of it that way. And I should probably get my face out of the way so you can kind of see these graphs here. Because always we have an image that represents the actual patient, and we have what it is, and then we have like the mechanism, and then we have the bottom line, right? So that's my goal. Okay, so now we're on to this next question. Here it is. We have a 45-year-old woman presenting to the clinic, and you can see her up there on the top left. She has a history of hypertension and is currently on lisinopril. Her weight has been stable, but she reports increasing thirst and occasional blurred vision. A screening test for diabetes mellitus is performed, and we measure the HbA1c and the threshold of 6.5. She is diagnosed with diabetes. The practice is considering changing the threshold to 6. Okay, so which of the following test characteristics is most likely increase in this new threshold? This is a question of biostats, folks. Biostats. Does anybody know the answer? Are you confidently thinking you guys know this answer here? Well, raising the threshold, we're on question 23, raising the threshold for a positive test to diagnose patients with a disease would decrease the sensitivity and increase the specificity. Okay, so decrease sensitivity. Yeah, Brahmdeep. Yeah, MD Ray. Woo, you guys are killing it out here. The answer is sensitivity. Very, very, very good. And it increases specificity. Okay. Why? What's the reason why? Well, there's a really good mnemonic here, like spin. You guys have probably heard like spin and snout. Well, I came up with one as well that I kind of liked. And that's like, if you're thinking about dating, a true positive test versus like a true negative trait. It's truly a positive trait. It's truly positive if somebody asks you, like, if you're a sensitive person, right? Oh, he's so sensitive. Oh my gosh. You should marry him. He's so sensitive. All right. Truly a positive trait. It's truly a negative trait if you ask somebody, who you dating, and they can't specify. They're like, oh, the blonde chick. All right. That's a truly a negative trait, right? So that's the specificity. And so that's like the true negative trait. And this is like a truly positive trait. Okay, so that's like a way to kind of think about these things. But just to kind of break this one down a little bit more easily, sensitivity is the true positive. So it's like all of which the people who have the disease. And it's the probability that the test detects the disease when it's present. Specificity is the true negatives, right? So those are all the ones that truly don't have it. And it's the probability of the negative, getting it right. The positive predictive value, what is that? Positive predictive value is the true positives divided by all the positives, right? And that depends on the disease prevalence. And the negative predictive value is the true negatives over all of the negatives, okay? That's just like some basic stuff, right? And so what lowering the cutoff does, so we go whoop. Basically what we're doing if we're lowering the cutoff, whoop. Oh, actually, you guys are seeing this in reverse. You know what I'm going to do real quick? I'm going to go to my Nikon camera, and I'm going to go to filters, and I'm going to flip myself. There we go. Now I'm actually pointing in the direction that I think it is, and I can actually go like this. Okay, so you're on a graph. And what you do when you lower the cutoff is you call more people positive. Because the way that this looks, the way that they actually test this, I think actually on NBME Form 30, they had like a graph that looks exactly like this. Okay. And then they'll go like this. And this right here, actually, I should let you guys kind of say, tell me how to make this graph here. So this axis here is the test results. And if this is the false negative here, what is this? Can you guys see? What's this? Who knows? If that right here is the false negative, what is this right here? And let's say that right here, the disease is present. And let's say right here, the disease is absent. All right. And this is the cutoff line. Do you guys know? Yes, yes, yes. Natish got it right. False positive. False positive. Okay. And then so like this right here, what is this? I should do it in a different color. This zone right here, what is that? And this zone right here, what is this? Yeah, good. You guys are getting it right. Natish got it right. Tony got it right. MD, good. MD Ray got it all right. Perfect. Okay, just testing. So really good stuff. Right here, this colored in area, good. Yeah, you're nailing it. Yes, true positive in red. Nailed it, 100%. And then that makes this thing over here the true negative. And so what happens? We move it to the left, and we're calling more people positive. That means you catch more of the actual disease people. So you catch more of the true positives, and you increase the sensitivity. Because remember what we said, it's truly a positive trait that he's so sensitive, right? You're increasing the sensitivity. But you also catch more of the healthy people by mistake. Those are the false positives, right? The false positives. And so you're lowering the specificity as well. Okay? So sensitive, truly positive. Specify, truly negative, right? And so you're lowering those who are truly negative. And so you're lowering the specificity. And so the answer, which is the following test characteristics most likely increases, is sensitivity. But if they were to make it harder on you guys, and I love making it harder on you guys, then you would also be lowering what? You'd also be lowering the specificity. Yeah, you guys are probably like already typing it in the chat. You're like, oh man, he said it before I could say it. But there's a latency. So what can we do? I have to take your word for it. And just send me your passes in the mail. That's how I'll know. So, jeez, I'm dying. Also, guys, just really quickly, what is happening here with this timer? Is this timer actually counting down, or is it? I feel like I'm like losing it because every time I look at the timer, I swear it's like 25 minutes. I'm like, has no time passed, or am I just checking this every 30 minutes? Oh my goodness! All right, folks. Bottom line here, yeah, lowering the threshold increases sensitivity for diabetes detection. Hopefully that makes a lot of sense. Let me know if this is a good format or if there's anything that I should change about this. Your guys' Saturday, I love it, man. Justin sounds cooler than a Netflix series. Well, my guy, I don't know what you're watching because there's some pretty freaking good shows on Netflix, and I recommend them. Just let me know. I could share with you my Letterboxd, and maybe I could change your mind about that. But I really appreciate the comment, and thank you so much, Justin. I'm really glad that you're sharing your Saturday with me. It does mean a lot, and I don't take that lightly. I really appreciate the time you guys have, and I just want to make it fun for you guys. All right, here we go, folks. Here we go. The next question, we're talking about the lay of the land, and I've generated 3 new images for you, and a new patient is in your ER room, and here is what they have to say. Boom. 45-year-old woman knocking at your door saying, "Hey, doc, I got some difficulty urinating, and I got a sensation of incomplete bladder emptying for the past 3 weeks. Hey, I've got no history of recurrent infections and trauma, but I have undergone a hysterectomy 6 weeks ago." Snip, snap, snip, snap. That's a vasectomy. But an examination of her bladder is palpable and distended. Post-void residual volume shows, oh, look at that. We got 400 milliliters of urine. Okay, thank you. Urodynamic testing reveals decreased detrusor muscle contraction. Which of the following nerves is most likely affected? Okay. Do you guys know this answer? Are you sure? Do you know what this is? Okay, so what's happening here? S2 to S4. Really appreciate it, guys. And I love the engagement. It just makes this so much fun. The pudental nerve, says Rondeep, the pudental. Anybody else have any ideas here? I love this. This is going to be good. We're going to have some good discussion about this one, I can tell. Some good discussion. Any other comments there? So just while you guys are like typing this up and thinking about it, pelvic surgery. So, right, how do we know pelvic surgery? Well, she had a hysterectomy, right? So she totally had pelvic surgery. Hysterectomy is where they remove all the parts of the uterus. Okay. There's a risk of injury to the what nerves? Okay. So I like this. We're going to have, I feel like we're going to have some really good discussion here. So basically, the answer that I would choose here, and we're going to be able to talk about this, is the pelvic splanchnic nerves. And so the key features of this question are going to be, there is urinary retention, and there's this 400 milliliters. Like, what do we do with that? Like 400 milliliters. Like, what's up with that, right? That's high post-void residual volume. And there's detrusor underactivity as well. And so that's like a parasympathetic damage, right? And so I agree that you can damage like the pudental. You can get down there and you can mess a lot of things up, believe me. But the detrusor underactivity is a parasympathetic problem. And so we got pelvic surgery and we got pelvic splanchnic damage. And that's in the S2 to the S4 area. Okay. And so we think of all these nerves and we're like, okay, how do we know? Well, the pelvic splanchnic nerve is the one that controls the parasympathetics, right? It controls the S2 to S4. It controls the detrusor contraction. So detrusor contraction, that's what causes voiding, right? Void. And then the internal urethral sphincter relaxation as well. All right, so that's what the pelvic splanchnic does. Okay, so parasympathetics, you're like, oh my gosh, those that control muscle contraction? False. They do control muscle contraction. They control the detrusor contraction, right? And also internal urethral sphincter relaxation. So it's not, the parasympathetic isn't about contraction and relaxation. The parasympathetic is about contracting or relaxing in a way that aligns with the parasympathetic system. The pudental nerve is also S2 to S4. So that's why I'm like, oh, I like that answer you chose, Ramdeep. That's a good answer. Because the pudental nerve is S2 to S4, right? And that is somatic, external urethral sphincter control, right? And that's more like with continence. And we'll talk about that in a second, but we're getting to the crux of this here. The femoral nerve. What about that guy? The femoral? L2 to L4. Okay, so that one is thigh extension. You can't see, but I'm doing my thigh extension here, not the bladder. So it's not femoral nerve. We can cross that one off. What about the sciatic nerve? Okay, L4 to S3 is the sciatic nerve. And that's the posterior. Oh, can you see? Yeah, that's the posterior thigh and the leg, not the bladder. And the iliohypogastric is also the like abdominal wall sensation. So I agree that we're down to those two answers. And now we just have to distinguish between them. And I think it's a really good answer, like the pudensal, but that's somatic control of the external urethral sphincter. And that's like continence, not detrusor contraction. And that's the only reason why I would not say pudensal. Very good job, guys. Very, very, very strong work. Good stuff there. The bottom line is that decreased detrusor contraction of the urinary retention suggests pelvic splanchnic nerve involvement post hysterectomy. All right. And so I'm going to cancel out of that and move myself over to the side so you can kind of see this diagram. I'm now this patient. And there we go. So does that make sense? Do you guys have any questions about that one? I thought that was a good, hard question. And you guys nailed it. So good work there. I really love the answer, Ramdeep. Really, really strong answer as well. So on to our next question. Oh my gosh, I just had deja vu. Okay. We're on to 34. Wait, no, we're not. How did we get up here? I thought we were on 25. Oh, brother. Oh, brother. Oh, I was just like going downwards. Okay. Yeah. Whoopsies. We're on 25. Honestly, I can't understand too much science. Oh, no, Justin, you got so much of it right. I'm so freaking impressed by you. Really, really impressed. Your answers have been spot on every single time. So that's insane. Okay, let's do this, folks. Let's do this. Diving into the next practice question. Let's put it on the screen. Boom. Look at this. It's a 3-year-old girl. Look, she's just chilling over there. And guys, I cannot wait for when I get this up and running. When I get my computer hooked up, this is a $4,000 computer that I bought just for this channel, just for you guys. And when I get this hooked up, I'll be able to like run images, like image to video. So I'm going to generate an image of the patient, and then I'm going to generate a video of that patient, like having those symptoms. And just so you guys know, I actually made a game last year where you diagnose patients and it takes you into a back room and it explains all of the medical content. So I love teaching like medical content and medical sciences, and I'm so passionate about this. Like, I just want you guys to know that, like, I'm really grateful for you guys being here because I care so much about this stuff. And so, anyways, we're ready to go. We got a 3-year-old girl. She's evaluated for developmental delay and frequent episodes of irritability. Oh, yeah, she's so cute. I know. She's adorable. Her parents mentioned they noticed a sweet-smelling odor on her breath. Okay, so what is that? Already, what's that sweet-smelling odor? I'll you guys think about that for a second, but that should be a giveaway. Physical examination shows hypotonia and eczema. Genetic testing reveals a mutation in the gene responsible for certain metabolic enzymes, leading to abnormal exon inclusion. Which of the following best explains the genetic mutation caused by the aberrant splicing observed in this patient? Okay. Wowza. Wowza indeed. All right, so if we don't know this one, then we're kind of up the river without a paddle. But the sweet smell and the splicing error, okay? Those are the two things I want you to dial in on this one. I'm stretching my legs out. Why am I stretching my legs out? Because we do not want to get what? Every 2 hours that we sit, we do not want to get a DVT, right? Deep vein thrombosis. So try to answer this question real quick. Just stretching my legs because I'm not trying to clot up, you know? How ironic would it be if I'm like, I get a deep vein thrombosis while I'm teaching about deep vein thrombosis, you know? That would be insane. So yeah, can you guys hear me, by the way, if I talk back from this place? Hopefully you can. The sweet smell, right? And a splicing error. I'm just gonna take a quick 10-second stretch, and I would recommend you guys do it too. Just give yourself a little stretch. And we'll be back in 10 seconds here. Yeah, go take a 10-second stretch, man. I think it's crazy that as doctors, we don't practice what we teach. Like in medical school, the biggest social hangout in residency is just drinking. And it's oh no, I mean, it's fine or whatever, but it's not good for you. It's literally a toxin. And then we're oh, let's sit down for 6 hours straight and then not stretch and then talk about deep vein thrombi. And it blows my mind sometimes. I'm guys, we got to practice what we preach. One thing that blows my mind too is that some of these AI models are better at diagnosing lung cancer than primary physicians with stethoscopes and like with just physical examination and taking a patient history. And I'm like, if that's true, why are we like establishing LLMs in every single PCP like clinic across the nation? And so I actually started working for a startup like 5 months ago, where we are trying to solve prior authorization problems like AI automation in healthcare. And oh man, ooh, get a little stress going. But I feel like you can either save like, I think it's like 230 years of life is one study as a physician, like treating people, diagnosing them with maple syrup urine disease, which is what we're about to cover in this topic. Or you can like solve the healthcare problems at a systemic level, and you could save hundreds of thousands of patients. Like I could try my whole entire life and I would never alleviate the amount of pain commensurate, or like I would never alleviate even like a small fraction of the pain that was caused by like people not understanding that Tylenol is okay to take during pregnancy. So like that's why I'm so passionate about health policy, and that's why I'm starting this YouTube channel. Because I'm like, gosh, like, you know, we can do our part in like improving science literacy and medical literacy and trying to make it fun. And you can make it fun with AI, you know, like you can generate the photo of this little kid and talk about like maple syrup disease, and maybe even later on we can even like smell it, and I don't know, just cool things happening. So we'll resume here in like 20 seconds. All right, guys, welcome back. Here we go. Get my iPad here so I can take some notes. All right, so do you guys know the answer to this question? Sweet smelling, right? So we got a clinical description: sweet smelling odor of the urine, developmental delay. What else we have here? Some irritability and some hypotonia and eczema. Yeah, that's everything. And so what's happening? This is maple syrup urine disease. It's a metabolic disorder that involves the abdominal, or actually not abdominal, the abnormal. And what is abnormal in this? What's the weird thing in this? Amino acids. The amino acids. That's what's abnormal in this. Okay. So what happens is there's a problem with the splice site, like there's a mutation in the splice sites, and that causes the abnormal exon inclusion or the skipping. And so there's a sweet smell of the breath and urine, and that is because there's the branched chain alpha ketoacid dehydrogenase deficiency. And there's this, maybe they have like a homemade protein formula that they're going to be giving this kid, and that's going to be high in certain like amino acids. And there's usually developmental delay and hypotonia and eczema, and that's like proving that it's a metabolic disorder. And there's the abnormal exon inclusions and the aberrant RNA splicing problem. Okay, so how the splicing works in your DNA is you get a section of introns and you have a section of exons. The introns are removed. We don't want those around. The exons are joined together, right? So exon over here, intron, exon. They're joined together. And there's a splice site, and I'll draw this in blue here. We have like a 5' site right over here. There's a 5' donor site, GU. And then we have a 3' acceptor site, AG, right? And mutations at these sites, right, can cause abnormal splicing. And so you get exon skipping, intron retention, cryptic splice sites activated, right? So if you mutate over here, it can cause a huge problem. Okay, and let me just set a timer so don't go over. Hey, Alexa, wake me up at 10:55.
Good morning, Blake. Alarm set for 10:55 a.m.
Okay, there we go. So that's when we're going to end, and we're going to get to as many questions as we can. But now we have like an end date, an end time in sight. Okay. So silent mutation in an intron, that would do nothing, right? It doesn't alter the splice site unless there's a splice site like yes, there's really just like a silent mutation. Who cares? Yeah, that's like almost never going to be the answer. Missense mutation in an exon, that one changes one amino acid, but it does not affect like the splicing itself. So that's not the answer. Okay. And frame shift mutation, that's going to cause a whole bunch of problems. Change of one amino acid, but that would not necessarily affect the splicing. So directly what's happening here is that there's a mutation of the splice acceptor site, is what's going on here. Okay, so missense, that changes the amino acid, but then the splicing would be normal. Okay, I'm gonna scroll down so we can kind of see these answer choices and the key explanations. And if you guys like, I'd be happy to put those in the future. It kind of explains things in a different way. But that's what we're dealing with in this patient. And then a missense mutation is just a single nucleotide change in a coding region that results in a different amino acid that's incorporated at the protein. So an example of a missense mutation is like you got your nice DNA here, and it's like GAG. Woo! What would be a missense mutation? Well, like a GTG. Because while this one codes for glutamate, this one right here codes for valine, right? That's a missense mutation. And that is the classic mutation, by the way. Those weren't just random for sickle cell. So this is the mutation that happens for sickle cell. And so the effect is you change one amino acid. It doesn't alter the actual like splicing sites. Okay. So the bottom line is right here. Mutations that affect the acceptor site lead to aberrant splicing and metabolic disorders, like phenylketonuria. Okay. And the next one is like a biostat question, but I kind of want to skip that. It's just a really easy question asking about the mean, median, and mode, which everybody kind of knows. Those are kind of freebies. You know, median is like actually in the middle. The mean can be skewed left or skewed right. So like it'd be skewed left here, skewed right there. And the mode is the most frequently seen, you know. So that's like the difference between them. And I just drew that out and you didn't see, sorry. This is the median. This is the mode, but skewed left. And this is, that's the mean, but skewed left. And this is the mean, but skewed right. And this is the mode. So everybody knows the mean, median, mode, so I'm not going to really harp on that. All right. So now on to our next question. We have in this one, a 45-year-old man. So I'll go over here and you can check him out. He comes into the clinic and he's like, oh, I got a fever, headache, and muscle aches that started 3 days ago after I did a hiking trip in the Appalachian Mountains. And we're examining him, and he's got this rash, tender lymphadenopathy, and lab test shows mildly elevated white blood cell counts. After suspecting tick-borne illness, the physician plans to initiate antibiotic treatment with a medication known to interfere with bacterial protein synthesis by blocking the attachment of amino acyl tRNA to the ribosomal receptor site. This medication is known for its contraindication during pregnancy due to its effects on fetal teeth and bones. Through which of the following mechanisms does this exert its antibacterial effects? And we have some answers here. Okay. So. Attachment. Blocks the attachment of amino acyl tRNA to the ribosomal receptor site. That should be making us think of a couple of mechanisms of antibiotics. So we have to talk about tetracyclines and ribosomal blocking patterns, right? So we have a tetracycline, and it's most likely going to be like doxycycline is very common. And tetracyclines, how do they work? We'll zoom on over to this question right here. Tetracyclines, these guys work by blocking amino acyl tRNA entry into the 30S ribosomal A site. That's their mechanism of action. That prevents the bacterial protein synthesis, and it's bacteriostatic. Okay? And so the breakdown here of what this guy is suffering from, he's got fever, headache, myalgias, which is like, myalgias are basically just muscle pain. And it could be caused by a whole lot of things. So it doesn't actually tell us a whole bunch of things. But maculopapular rash as well. And what else does he have? He's been hiking in the Appalachian Mountains, and that's going to be like a tick-borne disease location. So you think of rickettsia, that's a Rocky Mountain spotted fever. And then we use an antibiotic that binds the ribosome and causes teeth discoloration in pregnancy. And so that's going to be doxycycline or tetracycline. And so that teeth kind of problem really tells us that it's the prevention of the formation of amino acyl tRNA entry into the ribosome. So the mechanism of tetracyclines, as I mentioned, is that they bind to this 30S ribosomal subunit, and it prevents aminoacyl tRNA, right? It prevents tRNA from attaching to the A site. That's this whole shtick. And it halts the protein elongation. And it's bacteriostatic, so it just slows the growth. And the way you know this is there's a tick-borne disease. And then we know that there's the teeth discoloration, the bone problems, and that tells us it's a tetracycline, and that's the mechanism right here. Now let's look at the other answer choices and talk about why they're wrong. Cell wall synthesis. So that one is going to be beta lactams like penicillin, cephalosporins, vancomycins, right? Cell wall synthesis proteins, your penicillins, cephalosporins, beta lactams, vanc, all that good stuff. Disruption of the bacterial membrane integrity. That's daptomycin. It inserts into the membrane. So daptomycin. Integrity of the wall. It's going to be damaged there. Folate metabolism. So the folate is going to be TMP-SMX. That's trimethoprim is the dihydrofolate. And then RNA polymerase inhibition. So that's a rifampin. And rifampin, RNA, R for rifampin. Hey, Krishagal, video for ACT and videos helped improve to 29 to 33. Awesome. I'm so happy that your ACT has been improving. And guys, welcome. Other students have also been joining from the ACT channel. So let me actually post a link to that. If you guys have children who are studying for the ACT, we recently had somebody go from a 19 to a 34. Shugal just went from a 29 to a 33, which is insane. Awesome. I would say you're almost like ready to there's a world in which you can get into some Ivy Leagues with that score. So really, really good stuff. And I'm going to post a link to that channel so you guys can access my free ACT resources as well. So let me do that now. Copy, and I'm going to put this in the chat here. Is there a way that I can? So it's Ivy Tutoring. Could you drop a link to that chat? I have no idea how I can access this chat. Crucial call. But super, super good job. And maybe we can cover like one last thing in the ACT at the end here, if that's cool with you. Right now we're covering some medical content just because that's what some people on this channel are hoping to cover. But I'm going to go, if you guys want to get ACT tutoring and free ACT videos, I have tons and tons of resources for ACT. And let me post that as a community post right now. So create post and image. So I'm going to say, hey, everyone. Because I want you guys to have access to that free resources as well. I'm super happy that it's helped you on the ACT. 33 is an awesome score. Congrats. Okay, so I'm going to say, hey, everyone, if you want free ACT and SAT tutoring, visit this channel. And I'm going to say, this is what I mentioned in the live stream. Also, any of you guys in the live stream, when you fill out a consultation form for ACT tutoring, if you guys have like students who want ACT tutoring, just type in live stream tell me the code live stream, or say that you found me at the live stream, and I will give you a $30 off discount for tutoring for the ACT. So normally $90 an hour, but I can give you a $30 off discount if you mention live stream. So I just want to say that this is the channel I mentioned in the live stream today. So this is on the community post if you guys want to go follow it. Oh, I just posted my same channel, Ivy Tutoring Med. It's called Ivy Tutoring ACT, just like this one's Ivy Tutoring Med. That one is for the ACT. And we cover ACT content there, and all of our tutors are from Harvard as well. So thanks so much. I really appreciate that. Hey, thanks for posting the link. Yeah, I appreciate it. I got to figure out a way to kind of navigate this system better. Okay, so back to our lock-in live stream. And Krishagal, thank you so much. That's awesome. If you have any questions about the ACT, I'm happy to answer those as well as soon as I finish this section right here on the RNA and rifampin and stuff. So thank you so much for coming. I'm really happy that you joined this Saturday. All right, so yes, tetracycline, tetracycline is what I like to call it. And rifampin is an RNA polymerase inhibitor, right? And so we got a hiker in the Appalachians with fever, rash, and muscles, tick-borne disease, Rocky Mountain spotted fever, doxycycline. Okay, doxycycline blocks the aminoacyl tRNA from binding the 30S ribosome. And so here is the bottom line: antibiotic treatment for the tick-borne illness involves the aminoacyl. Okay, so also we tutor AP exams too. If you guys need help with APs, I'm actually interviewing somebody. That's the reason I have a stop The reason I have to stop right after this is I'm actually interviewing 2 employees for both Harvard students. They teach AP History and AP Calculus, and then AP Chemistry. So if you have anybody wants help with those, super happy to help and give you guys a good discount too if you mentioned the live stream. All right, so on to our next question. I think we'll do one on like the sagittal sutures and the lambda sutures and the bregmas real quick, and I'll do like a little. I think what I'll do is I'll just draw this out for you. So when you're looking at here's an oblong little face here, and here's like the nose. Oh my gosh, that's the world's worst drawing. I apologize. There we go. Okay, so this is our person, and we have these suture lines. Make sure you do this right. Okay, we got these suture lines. I'm gonna draw this in a different color so you kind of see. But this is the nose, this is where he's facing us. And this guy right here is called the bregma. Bregma. And this would be the coronal suture. Coronal. And this back here is a lambda. And this is the lambdoid suture. And this would be the sagittal suture. Okay, and that's going to be helpful as we answer this next question here. So I'm going to go over here and give you the question. And bada bing, bada boom. Oh my gosh, look at that little baby. Oh, 3-day male infant born at term is brought to the pediatrician by his parents. They are concerned about the shape of his head, which appears long and narrow. And indeed it does in that little photo. The pregnancy and delivery were uncomplicated. On physical examination, the infant's head is elongated in the antero-posterior direction and narrowed laterally. Neural examination is normal, and there's no evidence of increased intracranial pressure. Which of the following structures is most likely fused prematurely to result in this infant's head shape? Okay, so what fused? Okay, so it's long and narrow, and which one's long and narrow, and fusing those early? That, my friends, is the sagittal. Yes, Brahmdeep, nailed it. Yes, Brahmdeep. Yes, sagittal suture. Very, very good. So 3-year-old baby, long, narrow, right? There are no signs of brain pressure or anything else. This is, it's like a scapulopathy. And this happens when the sagittal suture closes too early, and that suture runs down the middle of the skull. And when it fuses prematurely, the skull can't grow sideways, right? Because think about it this way: you're fusing it, and so you can't have this growth. And so basically, it's just a cosmetic issue, unless you have like brain pressure problems, which sometimes you can have. But this baby doesn't have any of that, and so fortunately, in our fictitious baby, they're okay. So we have sagittal suture, and here's the bottom line for that one. And you can kind of check this one out while we go to our next question. I want to hit as many as possible before our time runs out together. By the way, would you guys like it if we did more of these live streams? Do you think they're helpful? Are they good for accountability? Let me know, because there's a world in which I just pop on every Saturday and I kind of walk through like 50 questions just for, just a quick 50. Maybe later this afternoon I could pop on, give you another quick 50. I don't know if it's good for like accountability, just to make sure that you're actually grinding, because you really should be studying like 8 hours a day. If you're in dedicated period. If not, then it's kind of chill. Just you can do a lot of things, but I digress. Okay, so that is the sagittal. So let me know if you guys want this format. If you like it, then that's great. And I think I'll do more of them. More of these would be awesome, Brahmdeep. Okay, sick. I think I might start doing this more, and I'll get the Twitch, and I'll get the TikTok, and I'll get the Instagram, and we'll just get everybody having a party. Yes, says Alberta. Alberta, thanks for joining the chat. I am so happy you joined today, Alberta. I just love meeting new people. It makes me very happy. Very, very pleased that we can spend this Saturday together. Okay, so let's dive into this next question. Boom, we got a 57-year-old man. He's got hypertension and diabetes and CKD. I feel like an auctioneer. Started on losartan. Boom. After 2 months, BP is controlled. You guys know this question. This is super classic. If you studied it enough, you know it. It's not anything about being intelligent. This is just like, hey, do you know the mechanism of these drugs? So I'm going to give you guys a chance to answer in the chat. Okay, Bram D says more. That'd be sick. Let's do it. Okay, so yeah, what do you guys think? Increased, decreased, and increased, and your answers are angiotensin 1, 2, and then bradykinin. So take a second, really just look at this, try to answer this question the right way, and then we'll dive in here. And the big hard one is really the bradykinin. Okay, so just think about that for a second. Think about the bradykinin, and then give me your answers in the chat. Because this is important, and you will see this guaranteed on test day, like 100%. This is totally going to be on the exam. Okay. There's no world in which this isn't tested. Okay, so while you guys do that, I'm going to start to break this down. This class of medicine is an ARB. And I think I like this yellow, which I haven't even used yet. Hold on, I'm going to use. I think I like the yellow that I was trying out the other day. Where's my yellow? B. We got a B in the chats. Nice. Thank you so much, Deep. Do we have any other answer choices? I love it. I love it. Okay, so this is an ARB, right? And he's taken losartan. Any of the TANs are ARBs, right? And so these ARBs are going to be, okay, Edith says D. Thank you, Edith, for joining the chat. Edith, so good to see you. Edith, have you heard of The Death of Edith Finch? Really good game, by the way. One of my favorite games of all time. Okay, Deep and Edith are fighting in the chat. I think it'd be funny to like have like your names, like you guys like mention something in the chat and they like fight. And then like I get like you like pop on Zoom and you're like, I think it's B because of this. I think it's D because of this. Okay, let's break this down here. Okay, so ARBs. These are known as angiotensin. What are they? 2 receptor blockers. Okay, angiotensin 2 receptor blockers. And so the question is asking, hey, what happens to his hormone levels because of this drug? So angiotensin 2 blocker, I like how we said decreased angiotensin. I like how we said decreased angiotensin. And we're saying also increased angiotensin and increased angiotensin. And then we're just talking about the bradykinin. So what gives? Well, losartan blocks angiotensin 2. And that means angiotensin 2 can no longer do its job, like raising blood pressure. Oh, Deep, Edith, you got a follower there. I think so, yes. So basically, the body senses less angiotensin 2 activity, and it makes more renin. More renin means more angiotensin 1. Angiotensin 1 is still converted into angiotensin 2 because the ACE still works. And so both the angiotensin 1 and the 2 levels go up, but angiotensin 2 can't do anything because the receptor is blocked, right? What about bradykinin, though? Okay, so bradykinin is only broken down by what? ACE, right? And so since losartan does not block ACE, bradykinin is not affected, right? Because bradykinin is broken down by ACE. Yeah, D said it. Okay, ACE inhibitor will increase bradykinin. Very good. Very, very good. Because if you're blocking that ACE, then it's not going to be broken down, and so bradykinin will be increased. Yes. Yeah, nailed it. And so what happens overall is angiotensin 1 is increased, right? And so our answer is going to be D. Cool beans. Cool beans. We feeling good about that one? Yeah, that was a good one. I like the battles when they occur here. Here are the trap answers and why they're wrong or right. And here's the bottom line. Yep, there it is. And that's all correct. Losartan ARB decreases angiotensin 2 and increases bradykinin while angiotensin 1 levels rise. Very good question. Almost guaranteed to see that on test day. Like, I'd be so shocked if that weren't on test day. I would be blown away. Okay, on to our next question. We're on question 30, right? I have lost myself. I numbered all these yesterday, and now I've lost them all. Okay, so question 30. I think this one, we're going to talk about CRP. Do you guys know what that is? C-reactive protein. What does it do? What does CRP do, huh? And where is it generated? That's what we need to know for this question. CRP, what does it do and where is it generated? So think about that for a second. And I'm going to give you a little bit of information. Usually infections. I know you can't see the question yet, but I just want to like talk about the concept and then we'll hit the question. So yeah, infections, autoimmune flares, tissue injuries, and then cytokine is released. Okay, so let's talk about our practice question in 3, 2, 1, boom. Yep. 67-year-old man presents to the clinic with complaints of fatigue and low-grade fever. APR, nice, like it. And joint pain over the last 3 weeks. He has a history of rheumatoid arthritis and is on methotrexate therapy. Lab tests reveal elevated acute phase reactants, including a significantly increased serum C-reactive protein, CRP level. Imaging studies are unremarkable for any new joint erosions. Which of the following organs is most responsible for the production of CRP? Kind of a factoid thing that you just have to really just memorize, honestly. But CRP is synthesized in the liver under the influence of IL-6. And remember, hot, T, bone, ache. 1, 2, 3, 4, 5, 6. IL-6, acute phase reactant. Yes, Edith got it right. Yes, acute phase reactant. Very, very good. So it's hot T-bone steak, where the S and the T is silent. Hot T-bone ache. That's the way to remember these. It's really powerful mnemonic. And basically, somebody has rheumatoid arthritis and they have a flare of inflammation. Okay? That's what's happening. And the immune system responds by churning out IL-6, like Edith said, acute phase reactant. And that tells the liver, hey, liver, let's produce some of this CRP. And CRP itself is an acute phase reactant, right? And it binds to the pathogens and it signals the inflammation and it rises really quickly in the blood. And it's not made by the spleen or the thymus, none of that. It's just made in the liver, okay? So that's the secret here. And we'll go up to the pathophysiology and so you guys can check that out and any associations as well. So rheumatoid arthritis, like in our question here, infections, serum amyloid, liver problem, and cardiovascular disease. So the trigger is infection, cytokine release, hepatic response, and there's the effect. Very, very, very good. Edith nailed this one completely. So the pathophysiology, just to kind of explain this generally, is like, I would say inflammation. And then the macrophages release IL-6. And then IL-6 acts on the hepatocytes, which are like the liver cells, right? And the liver produces CRP. And that activates complement. It promotes phagocytosis. It signals systemic inflammation. That's what it does. And that's the mechanism of CRP. So acute phase reactants, IL-6 simulation, all that good stuff. Here's the bottom line. CRP is primarily produced by the liver in response to inflammation. Very, very good. Very nice. Very, very nice. Like Borat. Okay. Going on to the next question, which is 31. And I think in the next live stream, I'm going to like flesh out all of these beforehand as well if I can, but I always love the feedback. So here's question 31. And we're going to be talking about some renal stuff. Oh, let's name the zones, the zones, the zones. Let's name the zones of the open sea. All right. So those are the two things that are going to be relevant for this question. And now let's dive into our actual question once it loads. And also we're going to talk about the inferior vena cava as well, but I don't want to give too much of this away. So here we have a 30-year-old man that I'm going to show you guys right here now. Boom, there he is. Oh my gosh, he's super shredded. He comes to the clinic and he has a dragging sensation in his right testicle, especially noticeable after physical exertion. He denies any trauma. He's super shredded. This is hilarious. And the mass does not transilluminate with pen light. And this is just cracking me up. Hold on. I need to do like a more normal. Oh shoot. I just clicked a button and I didn't mean to click it. There we go. Is that more normal? I feel like that's a little bit more normal, right? Okay. That last one was just like Arnold freaking Schwarzenegger's bodybuilder teacher. That was insane. Ultrasound confirms the presence of dilated veins with the panpeniform plexus, which the following is contributing to these findings. Good question right here. Good question. Just a weird image. Okay, so what's happening here? What's the pathophysiology? What's going on? Basically, what we need to know is about the testes. Your testicular veins, they drain into the left testicular vein, and then the left renal vein. So testes down here, right? Left testicular vein, and then they go to the left renal vein, and then they go into the IVC. Yes, Brahmdi said it. And to the left renal vein, and then to the IVC. And the right testicular vein, that one's different, right? And so I should probably have drawn this on the other side, because when we're thinking about things, I would always encourage us to like imagine this is a patient with a big old belly. And there's his testes, there's a renal, right? And so this is his right side. And so on the right side, the right testicular vein goes directly into the IVC. The left side has to go a different route, right? The left renal vein, and then it goes into the IVC. Yeah, direct IVC is Brahmdi. Brahmdi nailed it. Compression of the IVC by the lymph nodes or a tumor can obstruct the right-sided venous return. And so you have venous backup, and where? Where's the venous backup? The panpeniform plexus, right? And that causes a varicocele. Do we know what a varicocele is? That is like all the varicose veins in the spermatic cord. And it's an enlargement of the veins and a loose bag of skin that holds the testes called, what is it called? The scrotum. right? So that's a varicocele. And so you have a right-sided varicocele is going to be rare. And so you have to be evaluating it as like a malignancy because of how rare it is. And so we got a couple of answers here, and they're all kind of like long. What do you guys think the correct answer is? I didn't put it in chat, but basically, the correct answer is retroperitoneal lymphadenopathy that compresses the IVC, right? That's what's going on here. Direct drainage to the left renal vein. That one only applies to the left-sided varicoceles, right? Left-sided. How about compression to the right external iliac? All right, the right external iliac vein compression, that's too distal. The testicular vein just drains into the IVC, not the external iliac. How about some portal hypertension up in here, right? Some portal hypertension. Well, that causes caput medusae and hemorrhoids, not testicular varices. Caput and hemorrhoids, not testicular varices. What about venous drainage obstruction to the right inguinal? Well, that would cause a hernia, not venous pooling, right? Inguinal hernia. There's a hernia. All right, so our correct answer is indeed going to be B, and here's the explanation. Right-sided is rare because it drains directly into the IVC, and obstruction is most likely the cause. And then here are the answers that I kind of explained. Yeah, inguinal hernia is what it would cause, and portal hypertension would cause it. Oh, and esophageal varices as well is important to note. Okay, so hopefully that's good. What's crazy is that 40% of men with infertility actually have a varicocele, and so very important to know. And the clue is the bag of worms in the scrotum. Bag of worms in the scrotum. And then, the right side goes directly and the left side goes through the renal vein. Cool. How much time do we have left? Why does this say 25 minutes? I don't even know if that's counting. Is that counting down, guys? Oh, okay. We only have 5 minutes. So last question, okay? Last question, and then we're done. And then maybe, do you guys want to join later or not? Because I might just do another live stream and just join later, or I'll just make some more videos and edit them, or just keep working on the system that I have in play. I also have a platform that I'm building right now too. So a lot of things in the pipeline, a lot of things coming up, but I might just try to let you guys know beforehand because I don't want to monopolize your whole day. But if you guys need an accountability buddy, working through questions because you just can't do it yourself, then just join these live streams, and I'm super happy to work on stuff with you. Okay, so the last question here is question 32. We've gone through a lot, full explanation, 32 questions. That's no small potato. Okay. So this is going to be glucagon. Is our question. Glucagon. And what does it do? I got some notes here on this question that I wanted to bring up. And let me just do that real quick. So glucagon does a couple of things. It's when the glucose is gone, right? And that increases glycogenolysis. This also increases gluconeogenesis. And this also increases lipolysis. And this also increases one more thing, which is amino acid catabolism. Okay, and so suppression of glucagon lowers the blood glucose, lowers lipolysis, lowers amino acid stuff. And lipolysis, what you need to know about lipolysis is that this, make a video setting up Anki. Ooh, that's a good idea. Also, welcome Singh. I don't know if this is Brahmdeep Singh as well or another Singh. Use Anki for people struggling with retention. Yes, 100%. In fact, my new platform integrates with Anki for free. And so I'm gonna release Ivy Med once I hit 1,250 subscribers, and I'm gonna release that for free. So it'll just be a way that you guys can do practice questions, and then I'll give you my Anki decks. I also have a Chrome extension because I mentioned I have a computer science background from Harvard, and so I actually developed a Chrome extension that releases the Anki cards from UWorld. And so it's literally I got a text from somebody who said the only reason they passed up one was because of that Chrome extension. And I'm selling that for $50, and I give it to all of my students as well, just for free, right? So if you want to be one of my students, do some one-on-one tutoring, visit ivytutoring.net, and I'll link you up with a Harvard-trained MD or a medical student as well, if you're comfortable with that. And basically, yeah, they'll be guaranteed from Harvard, and the prices are they're 50% what everybody else charges. Just look for step one tutoring. It's the lowest I saw on some other competitors, which I won't name, is $180, $220 an hour. We're charging $90. So really consider that, and it comes with the Chrome extension. But yes, to answer, yes, I'm 100% gonna give you that material. Super happy to help. And I'll have to make a video as well. Right now, I'm working a full-time job as like a consultant for hospitals, and I'm working on like some AI criteria, and that's why I have all these computers lying around. And so I'm a little bit busy, but I would very happily do that. And all of my students who sign up get to mention 3 topics. Like Martha in the chat here is one of my students, and I'm working on those videos in the queue. And I think there might have been a couple more students in the chat as well. So you guys get to recommend the topics, and soon I'm going to launch like a Patreon, and I'm going to launch like a channel membership where you guys can just say, hey, what's the next video you want? And I will dedicate like an hour of my day, make that video for you. So just in case you guys want to join, you can't join yet because we haven't reached the watch time or whatever, but you can help out by like sharing awareness of this channel, I guess. And if you want that immediately before we have like the channel partnership stuff, then, oh, hey Alexa, cancel my alarm. Then just visit ivtutoring.net and I will help you out. So thanks so much for that. Okay, so last question. Alexa, cancel the music. She's going to start playing music. I have it hooked up to my lights, as you probably saw. Hey, watch this. Hey, Alexa, turn my lights red. And let's do this question. Hey, Alexa, turn my lights red. Hey, Alexa, turn my lights red.
Okay.
There we go. Last question. All right, we're going to do this really quickly. 6-year-old woman, you can see her here, and she's got all this stuff. Metabolic process most likely explains her disease. Okay, so we're just going to dive right in because I got an interview with 2 of these tutors, actually, that I have to check out their quality, make sure they're good, they're able to teach us content and stuff. But this is for other subjects. This patient has weight loss, right? Severe hyperglycemia, and they've got a rash, necrolytic migratory erythema, and what else? She's got glucagonoma, so that's a tumor of the pancreatic alpha cells. And so glucagon raises the blood sugar by stimulating gluconeogenesis and glycogen breakdown. And so the patient would likely increase what? The answer is gluconeogenesis. Cool. That's the answer. All right. So not much more to say about this one. I mean, glycogen synthesis. Glucagon stimulates glycogen breakdown. That'd be silly. That'd be crazy. Protein synthesis. That one is glucagon would cause protein breakdown, right? As I mentioned, the catabolic state. Yeah, you nailed it. You nailed it, Bromdeep. And cholesterol esterification, that is not directly affected by glucagon. And so, no. And then lactate production, glucagon favors gluconeogenesis, not anaerobic glycolysis. Okay, so hopefully that makes sense. And guys, I think that will be it for this live stream. I will join later. Hopefully this has been super helpful. I've got some interviews I got to run to, and then I have some tutoring sessions this afternoon. If you guys want tutoring, then just visit ivtutoring.net, and I can get you that same discounted price. Just look abroad for step 1 tutoring. It's the best you'll find. And if it isn't, let me know. I'll price match. I don't care, right? My goal is not to make a bunch of money. My goal is to help you guys get aligned with the resources you need. Thank you guys so much for joining. This has been awesome. I love interacting with you guys. Let me look at people in the chats here. Bromdeep, Edith, Alberta. Thank you so much. Tony, Jessen, Krushgal. Thanks so much, you guys, for joining. This has been an awesome little session. MD Ray. And we got, who else? Nathaniel, Sulman, Omar. Guys, this is awesome. Thanks so much for participating and chatting. Hasmita, Jim, and this has just been awesome. Ken, thank you guys all for joining, and I hope you guys have an amazing rest of your day. Let me know which topics you'd like to see me cover in the future, and I'm just super happy to have been able to share this early Saturday morning with you guys. If you like this, we'll do this more in the future. If you want tutoring, you know where to go. If you want Chrome extensions to help you with UWorld, I sell that as well on my channel. Any software that you buy, I will personally get on a Zoom call and help you install it. And so, yeah, don't worry about worrying about like how to install the software. I'm happy to help you do a free call on Zoom just to help you kind of get that set up. Guys, thank you so much. It's been a privilege and a pleasure just talking with you guys. Oh, hey, and there's somebody in the chat there, Jessen and Mango lock in. Oh, I caught the end of the stream, Mango. Don't worry. You can visit my channel, Mango, and you can watch it there. I'm just going to post that. Martha, thank you so much for joining. We'll see you soon with your with the tutoring there. I'm super happy to have you on board, Martha. Martha's already passed step 1. She is just doing it again because the time lapsed. Mango Lock In, thank you so much. Be there for lead chess next time. Yeah, I also play chess on Twitch if you guys want to join. I am a chess master. I'm not a national master, but I'm a arena-fied master. So if you guys are interested in watching me play chess, you're 1,100. Nice, you'll get there. I just recently hit the 2,200 limit. So I play a lot of bullet chess online on my channel. It's called Blake on Call. I'm going to post that to the channel so you guys can see that. Here, and then my channel is called Blake on Call. You know, it's because, you know, you're on call, you know, in the pediatric clinic, but you want to play a little round of chess. So I share that on Twitch. You guys can follow me on Twitch. I'll post that to the YouTube channel as well. And let me just check the live streams here. Thank you so much, everybody, if you're leaving the channel now. But guys, this has been a pleasure, and we'll see you guys soon. Thank you so much, Mango. Hey, Jessen, thank you so much for joining. We'll see you guys soon. Really appreciate you guys popping along here, and make sure you guys study. Lock in for the rest of the day, okay? Make sure you guys, this isn't the only work you've done. So I have to go to my next meeting. You guys have a wonderful, wonderful time. Thank you so much, and it's such a privilege to be here. Remember also, if you guys are struggling with any thoughts or whatever, no feeling is final. Tomorrow's going to be a big day, and you guys are going to do amazing things with your life. Remember that each day can be an amazing day. Just wonderful things can happen. Just believe in that, and you guys are going to be okay. So we'll see you guys. Take